Hello everyone. So welcome to today's session. As you all know, today we are going to discuss FMGE IBGs, that is mainly regarding the orthopedics. So hope you're all ready, waiting for the class. So let's start the class without any delay. So as we have already told, this is mainly the image based questions. So we have segregated all the image questions. So let us start the topic. So before starting the topic, what are the those? Good evening, Utpal. Good evening, Vasant. So, for before starting the session, let us discuss what are those important topics which you need to revise before going to the exam 1 or 2 days before. The first topic, what I want to tell you is about the nerve injury. My Hindi is awesome, yeah, but your spelling is not awesome. So first, the topic which you have to revise for the exam is the nerve injuries. So after nerve injury, so nerve injuries may you have to revise the three important nerves, the median, ulnar, and the radial nerve, the important tests, right? So first topic you're going to write or revise is nerve injury, right? And the second topic, what you're going to revise most importantly is the joint disorders. In the joint disorders, it is very important for you and between rheumatoid and arthritis especially, and then you various other diseases like the gout or hemophilic arthritis. Okay, so joint disorders is the next the third one is the right. So tumors, usually if they ask questions from ortho, it is mainly from tumor. So, Utpal, I will talk in Hindi, but as I'm from South, as you all know, my Hindi is not as fluent as yours. Okay, please excuse me for this time. From next time, I will learn Hindi and come back. Okay, so now the third topic, what you're going to revise before the exam is tumors, right? So, tumors is very important. So, nerve injuries, joint disorders, and tumors. And the fourth one I want to put at as the instruments and the implants. So when we talk about this image-based questions, no, usually they put up one instrument is mainly used in OT. If you have regularly attend your postings, you know what are those important, regular instruments, the bone clamp and all. And the implants are very important when they ask you about the X-ray. So they may put up a intermedullary interlocking nail for the tibia or the femur. So that wise it could be an important, right? So these are some of the few important topics which you revise, and never to forget polytrauma. So polytrauma में क्या होता है? See, what you have to revise in polytrauma is not about the treatment, but mainly what you have to revise is the classification, mainly the Dustello-Anderson's classification, and then the complications. So complications, they usually ask you regarding the fat embolism, which is very important. No? And then the other one is your compartment syndrome. So the compartment syndrome. So these two are important questions. And as ortho is full of fractures and all, so you have to revise all the fracture names and then all the tests, right? So the sports medicine is included in all these tests, right? So various test names we are going to revise today. So those test names and the fracture eponym. So what type of fracture, what is the, so these are few important topics on the whole. Now let us start with the tumors, right? Okay, before so a lot of things are happening in the FMGE, so they have increased your internship period maybe to like 3 years. So whatever might be the thing, so whatever is happening outside should never affect your inner mind, right? So what is in your control, right? So whatever is in your control, you should try to control it. So this is out of your control, right? Okay, do you have any voice issues? Nehit, yes, let me check for that. Okay, Ritvik, no voice issue. So probably Nehit, it is maybe your Wi-Fi is not proper. Please check at your end. Okay, fine. So now, what I want to actually tell you is whatever the chaos which is happening outside the world, which is not out of your control, never try to think about them. Only think things which are under your control. So what is that important thing under your control is this study. So you have to read. Then next one is the revision. Then you're going to attend the various tests which are being conducted by various institutes. So we are also conducting regularly based tests. So you have to attend these. Okay, so this is what you can control. So yours, whatever you're studying, the study material, so don't stick only to one important material. Don't keep on changing the resource one. And then the main important key is your review. So this is in your control. So try to take control of these things, and whatever happens which is not under your control, leave the universe will take care of it. And we always think that we never can do, like for example, when I took ortho, I really thought that I am not at all fit for this profession. Even when after clearing my PG also, I still have that thing in my, where you have to be where where probably I don't excel in this, but dheere dheere later on. So as we keep on going, as I keep on practicing surgery over the patients, now I feel that I'm fit for this. So we always think that we are not meant for some particular things in us, but please remember, we are always stronger than what we think. So putting all the chaos, putting all those worries, tensions aside, we are going to start the topic today. And these two, yeah, first time female orthopedics, there many are there, but yeah, but now the trend is towards female people also, like female residents in ortho. We'll see most of them, and I hope to see more and more from your group also. So for that, you need to clear this FMG exam, right? So let us start the session. So now what we'll do, I will put up the image and you are going to answer first. Even if it is wrong, try to answer. Because when you answer and if I correct it, you will remember it for your lifetime. Probably this question might come in the exam and you might do correct in the exam, right? So now let us start. Yes, the first one is very good. It is osteochondroma. Very, very good. It is osteochondroma. But what are those salient features, what you have to remember regarding your osteochondroma? So the first one, what you have to remember is, what is this actually? This is nothing but an tumor. Yes, but it is not actually a tumor. So this is not actually a tumor. This is an aberrant. What is meaning by aberrant? So some mistake which is happening in the growth plate. So there is some mistake which is happening in the growth plate, and this is an extra growth of the cartilage and the bone, right? So what is actually an osteochondroma? It is nothing but an, what is the other name? Exostosis, right? The other name for this is exostosis. So uh, what is that important thing which you have to remember whenever you see the X-ray? Whenever there is an extra growth of the bone. So if you see the extra growth of the bone, yes, and what is that one important thing? Because the bone grows like this. So this is the epiphysis, right? This is the growth plate here, and now uh, the formation of the bone is towards the proximal side of the femur, hence this is away from the joint. So always the osteochondroma grows away from the joint. That is because there is, what you have to remember, you have to remember that the growth plate is usually the reason for this extra growth, the osteochondroma. And what is the thing which you have to remember? This is a extra bony growth, but this is covered by what? Yes, there is a cartilaginous cap over it. So you will see a cartilaginous cap over it. And why are we concerned about this cartilaginous cap? Because this is the reason why we have to think about the malignancy of this particular condition. So you are most likely to see the chondrosarcoma in this cartilaginous cap, right? So it might lead to chondrosarcoma. So why is Utpal telling us to take the MRI of this thing? So in the MRI, what you see is, the first thing what you see is the continuation of the marrow. So this is the marrow. And now the beauty of this osteochondroma is the marrow is continuing into this particular extra growth also. So this is one important feature which you have to look in of MRI to segregate it from the other tumor. So whenever the radiologist specifies that the marrow of that original bone, is continuous with that extra growth, this confirms the diagnosis of osteochondroma. Then once you're confirming the diagnosis of osteochondroma, you have to think about the cartilaginous cap. What is the size of the cartilage? So whenever it is more than 2 centimeters, it is increasing in size, rapid increasing of tumor, then you have to suspect about chondrosarcoma, right? So this is the important things which you have to remember about your uh, osteochondroma, right? So what is the name given to multiple exostosis? Yes, multiple exostosis. What is this is called as? Called as diaphyseal achalasia. What is the term given to multiple exostosis? That means whenever you see an exostosis, a person or a patient, you have to even look for various other areas where it can develop, right? Most commonly, it is seen around the knee. Sometimes it is seen in the scapula also, and it can be seen in the clavicle also. So you have to check. So the osteochondroma has a tendency to present as multiple sites. So whenever you see such multiple exostosis, this is called as diaphyseal achalasia. So that is about the osteochondroma. So those are the important points which you have to remember. What is the next one? The next one is, yes, the next one is, so whenever they say a question about osteoid osteoma, there are certain salient features again. So what are those important things about osteoid osteoma? So this is nothing but a small nidus like tube. So this is small nidus like tube, right? And here, what is the most important thing is the size. The size is less than 2 nidus, and usually this nidus has the potential to produce prostaglandins, especially the prostaglandin E. Okay, the prostaglandin E2. So this prostaglandin, whenever there is a release of prostaglandins, it will result in pain, right? So this pain is mostly seen in the night time, right? So in the night time, and then the patient complains about this night pains, and then whenever these pains are relieved by NSAIDs. So prostaglandins inhibitor, NSAIDs are nothing but prostaglandins inhibitor. This gets inhibited and the pain. So this is also considered as the therapeutic test for your osteoid. Right? Hope you're all following. Am I going fast or slow? So this is about the osteoid osteoma. And what is the treatment? What is the important treatment? So treatment is usually radio frequency ablation. So you can treat with radio frequency in case of osteoid osteoma. So why I'm specifically telling uh, the size of it. So it is less than 2 centimeters. It is a small nidus and all. So whenever the same features, it is present as in more than 2 centimeters. So what is this called? Then you have to even think of one differential diagnosis, that is osteoblastoma. So how is this? Usually this has been asked recently in the exam. So they have put up this x-ray, and when you see this x-ray, you can only see that there is some extra growth of the bone. You can really not see any nidus over here. You can only see the overgrowth of the bone, or there is some callus like formation there, or there would be some thickening of the bone at that particular point. And this should raise the suspicion of osteoid. And what is the investigation of choice for this? Yes, the investigation of choice is, yes, it is the CT scan. So CT scan is the investigation of choice, where you will see the bone here. So you will see the extra bone, right? So this nidus, which is covered by bone, is the CT scan. So whenever you want to diagnose osteoid is what? Bone, right? So you want to see calcium, then go for CT scan. If you want to see marrow, then go for MRI. So now if you see the osteochondroma, what we have taken, the investigation of choice for osteochondroma was MRI, because you want to see the marrow continuity and the cartilaginous cap, right? And here what do you want to see? You want to see the bone, the nidus. So the investigation of choice is CT scan in case of your osteoid osteoma. And what are those important things? I have told you the prostaglandins are released, and usually they present pain succeeding with the sites, and this is also a therapeutic test. And now the treatment is radiofrequency ablation. What you have to remember, the size which is less than 2 centimeters is osteoid or yes. And now what is this? Yes, what is this? Very, very important. This is your shepherd crook deformity. Very, very important question. Your shepherd crook deformity. So where do you see this shepherd crook deformity? So what is actually shepherd crook deformity? So this is something like the shepherds who hold their sticks, right? So this is the shepherd crook, right? And why the name is given to such a thing? So this is mainly seen in case of a condition which is called as, yes, fibrous dysplasia. Very good. So this is fibrous dysplasia, and this is your deformity, that is a shepherd crook deformity. And what is the things what you have to remember about fibrous dysplasia? Okay, the first one is the marrow. The marrow is replaced by the fibrous tissue. Hence, the appearance is like your ground glass appearance. So, ground glass appearance is seen on the X-ray. So, patient, because of this, they present with what? They usually present with pathological fractures. They usually present with pathological fracture, right? So this is about the fibrous dysplasia. And similarly, I've told you the osteochondroma, what we have discussed is we can see as multiple size. So it present as multiple lesion. So similarly, this fibrous dysplasia also present as multiple lesions. So what is the syndrome which is associated with it? Yes, quickly, the syndrome where you see polyostotic fibrous dysplasia and precocious puberty. Yes, this is seen in, what is this? This is McCune-Albright syndrome. So seen in your McCune-Albright syndrome, right? Very important. What is McCune-Albright syndrome? Where multiple polyostotic fibrous dysplasia with precocious puberty usually is called as your, yes, McCune-Albright syndrome. Very good. So that is about the fibrous dysplasia. What you this is usually, again, it is very, very important IBQ. That is McCune-Albright syndrome, or whatever they may ask. They'll put up this X-ray and ask you to identify the condition. This is fibrous dysplasia, the shepherd deformity, where usually the marrow is replaced with the fibrous tissue, right? And then the syndrome which is associated with it is the McCune-Albright syndrome, right? So that is about the fibrous display. Then what is this? So you can see there is some. So first, before that, what is this? So the next one, what you are going to learn is some of the benign tumors. Benign tumors. And these benign tumors, first to start with is the UB. So what is UBC? UBC is nothing but a simple bone cyst. So whenever you see some fluid occupying lesion in the bone, you can name that as cyst, right? So what is cyst? It is nothing but a fluid. No, I am asking about this. That is not GCT. So this is UBC, simple bone cyst. So whenever there is a fluid which is occupied, and the fluid occupying lesion is called. So why it is called a simple bone cyst? This is called a simple bone cyst because it is not aggressively looking, right? So the boundaries are well marked. You can see the boundaries are well marked here. So it is not aggressively looking. It is a simple bone cyst where you see the diaphysis, the diameter of this is equal to the cortical diameter, right? So this area is almost equal to it, right? It is not expansile, it is not eccentric or something. It is naturally located, and but it is cystic in nature. So hence it is called a simple bone cyst. So where usually you see this simple bone cyst? Usually we see proximal humerus. So this simple bone cyst, he has a tendency to occupy mainly the proximal. And what is the important sign which you have to remember in case of simple bone cyst? What is the sign? The X-ray finding. It is your yes, the fallen leaf sign. So the fallen leaf sign, where you see a fallen leaf sign. So the fallen leaf sign is usually seen in a pathological fracture of the simple bones. So whenever a person is having a simple bone cyst and now there is a fracture, if there is a fracture here and there is some tissue which is fall, the bone pieces will fall into that fluid. This is called as a fallen leaf sign, yes, or the trap door sign. Very good. The fallen leaf sign or the trap door sign is seen in case of a fracture presenting with simple bone, right? So simple bone cyst, whenever there is a pathological fracture only, you see this, a fallen leaf sign or the trap door sign. So what is the treatment? What is the treatment? Again, it is a surgical management, but usually you can try a dose of intralesional steroids. So you can try a dose of intralesional steroids and then you can subside the cyst. This is about the simple bone cyst. Now what is this? Now, what is this? I have seen somebody answering this as Sahil has answered it as GC and telling me that there are soap bubbles. I don't think so. So the aspiration, yeah, cystic aspiration is not usually recommended because there will be a recurrence of it. So you should always put this, you should always destroy the cyst wall. So this destruction of the cyst wall is mainly by giving any, right? So you have to go for that. So, okay, now somebody is telling me this as GCT, right? Then I'll show you what is actually GCT. What is this? Yes, Sahil, this is ABC. Very good. This is this particular image which you're seeing now on the screen is your ABC. So what is ABC? It is nothing but your aneurysmal bone cyst. Aneurysmal bone cyst. So the word aneurysm is related to blood vessel. Hence, this is related to blood-filled fluid cavity. Blood-filled. Okay, it is a blood filled cavity. This is an ABC. So why this is not a GCT? Usually we have a confusion between ABC and GCT, but one thing which divides it is ABC, the site of origin is from the metaphysis, right? Metaphysis. But whereas your GCT, so this is your GCT. You see the GCT, this is clearly from this particular region. So what is this particular region? This is your epi, right? So GCT, the region is epiphysis, and see these two, you have to see. So now this is your ABC, this is your GCT. If you see, there is slight difference. So this AP is from the metaphysis, whereas GCT is from epiphysis. So very good, Sahil and Ritvik. Okay, so that is about the region or the location where these two origin. And what is the main important thing? What I want to tell you about this AB is aneurysmal bone cyst. Again, this is also usually it is eccentric and it is expansile. So how would you say this expansile? Again, you see, we will draw a line again like this. See, this is the actually the cortex line, right? So it is extending from the cortex. Here, if you see the simple bone cyst, see almost this is equaling the cortex, not going beyond the cortex. So here it is going beyond the cortex, so that means it is eccentric, that means it is expansile, right? And now mostly it is a blood filled cavity, as I told you. So whenever you take the MRI, whenever you take the MRI to see this particular condition, it is presenting with your fluid level. So there are multiple fluid levels, you see. So whenever you see such multiple fluid levels, so this is indicative of ABC, that is aneurysmal bone cyst. So this is your aneurysmal bone cyst where you see this multiple fluid level. So this is the multiple fluid levels where so this is the ABC, that is the aneurysmal bone cyst, right? So what is again the treatment for it? So the treatment for it is again, it is also, it is sometimes whenever this occurs in sacrum. So such areas you can go for your radiotherapy, right? Or radio ablation. So certain areas where you can't do surgery, you have to go for radiotherapy or radiation, especially in areas like sacrum. Also, they might present with AB. Such areas you go for help with again intralesional radiotherapy. So there are certain various modalities where you can treat with them. So if it is normal thing, then you can just go for excision, right? So that is about your uh, aneurysmal bone cyst. Now coming to your giant cell tumor. So what is this? Very, 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 very important. All eyes on GCT now. So GCT, what is very, very important thing, what I want to tell you is this is a epiphyseal origin, right? So this is seen from the epiphysis. As you already mentioned, yes, this is a soap bubble appearance where you see, and then what you see is, what you see, it is again eccentric as we discussed in ABC. Again, it is expansile and it is encroaching on the joint, but never destroys the joint. So it is encroaching the joint. So it is, you see that it is almost touching the joint. So this is encroaching onto the joint, but will never cross the joint line. Usually it will never cross the joint line. So that is the important thing which regarding your giant cell tube, right? And what is one more important thing which you have to remember? So how do you treat it? So the treatment, so this is supposed to be an aggressive but a benign tumor. So this is the important thing which you have to remember. So this is an aggressive tumor, but it is a benign. So then what do I mean by aggressive? Yes, it is eggshell crackling, but it is not a very important finding that eggshell crackling you see in a big G, that is by palpitation. So but whenever you touch the particular tumor, you can hear the eggshell cracking, but it is very important point. What I want to remind you is that why did I say it as an aggressive tumor? So even though I tell you that the GC is a benign tumor, I am again quoting it as an aggressive. So what is that aggression means? So the aggression here is based upon the recurrence. So here you see that the GCT will keep on recurring. Yes, the treatment is extended curettage, I agree. But the question what I asked is about the aggressive nature. This aggressive nature to its recurrence. So GCT, very, very careful. And favorite site for GCT is ECT loves the knee joint. So usually it is present around knee joint. After knee joint, the second location is your distal radius. So the second location after knee joint is your distal radius. Now coming to what is the extended curettage. So the treatment for GCT is always surgical treatment. Before that, you have to remember this particular drug, denosumab. This is being given to patients for but there are two schools of thought. So now again they have come up with various ideas that denosumab is working, but once you stop giving denosumab to the patient, again there is a high chances of recurrence, right? So just remember it, this they may ask you, so what is the one drug which is used in treatment of GCT? That is denosumab, that you have to remember. After that, what you have to remember is the treatment, that is your extended curettage. So you're going to treat extended curettage. Why extended curettage? Because we already know that this is an aggressive tumor where there is a high chance of recurrence. So this tumor keeps on coming back, so you have to destroy it from the roots, right? So here simple curettage is, so here ABC is curettage, so we know this excision is not, but here the curettage what we're going. But for GCD, the treatment is extended curettage. So what does I mean by the word extended? That means we are going to do something else with curettage. So curettage is nothing. What do? You open that particular site. So for example, here this is GCD, the distal radius. So you open up. So this is your skin and all, muscle tissue and all. You approach the GCT. After approaching, you completely scoop up. So you use the instrument scoop. There is an instrument as curate or scoop. So you completely curate it. So you will completely take all the curate matlab you will take out all the tissue from this, right? So after taking all the tissue from the cyst, what you do is still you have to be very careful, because now we are going to fill up this one particular important thing, that is your liquid nitrogen or the bone cement or the. So these are three important things which we regularly use, right? So how do these help? So when I put a bone cement is PMA, polymethyl methyl. That is the. So what do? You mix the bone cement, then you put. What does this do? Lot of heat. So that is bone cement causes the exothermic reaction. So it is believed that this heat generation by the bone cement will destroy the cyst wall and prevent. Similarly with the liquid nitrogen and similarly, right? So this is as your extended curator. So you're going to scoop, you're going to curate entire cyst, and then you're going to put few ingredients. That is your, it could be any one, liquid nitrogen or phenol or your own sim. So anyone, not all the three, anyone you're going to put. So then that is your extended treatment for your uh, gain cell tumor. So what are the important questions here? First, they're going to ask you about the site, that is the devices. And one more important thing, what they're going to ask is usually in after skeletal maturity. So that is the important thing. After skeletal maturity ka matlab kya hai? So it means that it is in after the physis. So once the physis fuse, and then there is a chance of GC. So usually whenever you see the X-rays, you have to always for the fusion of the physis for differential. So these are the important things what you have to remember. First, it occurs in epiphysis. It is usually seen after skeletal maturity. The next important location is distal radius. Then what is the appearance on the X-ray? X-ray, you can see it as soap bubble appearance. It is usually expansile and thick and usually encroaching. It means it is like kissing the joint. It goes near the joint, never destroy. Okay, it obeys the line. It obeys the line, right? And then what is the treatment? So we already know this is an aggressive tumor. So the extended curettage, where we are using three important things. Number is liquid nitrogen, cement, and that completes the GCT. And then what is this? So usually just remember, whenever they put hand X-ray or feet X-ray and they show you something like this, something lytic lesion, right? Lytic lesion and some calcifications around it. So this is nothing but Enchondroma. Enchondroma का मतलब क्या है? It is arising from the cartilage, right? Okay, Chota doctor, thank you so much. So it is nothing. I'll just keep on revising so that you get in the exam. That is the okay. Now the next one is, this is the tumor. So here you can see something which is lytic and seen in the small bones, right? So this is the small bones, shorter bones, where you see the hands and. So whenever there is an X-ray of this hand and whenever you see a lytic lesion and sometimes associated with some calcification, such as your popcorn calcification or some calcifications here and there. So you have to always think about this condition. This is called as the enchondroma. Enchondroma, that means cartilage or is end. So what is that? Again, important things you have to remember about enchondroma. So the first one is Ollier's disease. So what is Ollier's disease? It is nothing but multiple enchondromatosis. That means there are various lesions. So it is poly lesion. Like you can see it in the multiple places, right? So this is multiple enchondromatosis. So whenever this is associated with the hemangiomas, what is this called? Multiple enchondromosis plus hemangiomas. Yeah, that is nothing but your, very good, it is your Maffucci's syndrome. So what is Maffucci? Maffucci, yeah, Maffucci's syndrome is nothing but what you see is, first in the hand you will see multiple enchondromas. So whenever you take the X-ray, you see multiple lesions of enchondroma. And then you see on the skin, you see multiple hemangiomas, and also on the x-ray you can see plebolids, that is stone formation. So there is multiple stone like formation on the x-ray. So all this put together is called your Maffucci syndrome. Maffucci syndrome, right? So multiple enchondromatosis, simply it is enchondromatosis, it is oleus. If it is associated with the hemangiomas and plebolids, then it is called your Maffucci, right? So that is the two important things which you have to remember. So now I hope we have covered the benign tumors, so osteochondroma, osteoidoma, fibrous dysplasia, UBC, ABC, GCT, and enchondroma. Now let's talk about the malignant variety. So these are all the benign variety which we spoke. Now we are coming to the malignant variety. The first and foremost one which you have to remember is this. So this is very, very important. What is this? Yes, this is osteosarcoma. So what is osteosarcoma? Most common primary malignant. So most primary bone malignant, your osteosarcoma. Very good. First thing what you have to remember is it is a bone forming tumor. It is a bone forming tumor. इसका मतलब क्या है? Bone forming tumor का मतलब क्या है? It means it forms bone which is called as osteoid. Osteoid is nothing but bone. But where exactly it forms the osteoid? This osteoid is formed along the capillaries, or it can be formed along the Sharpie's fibers. So what are the Sharpie's fibers? If you remember, go back to basics. The periosteum is attached to the bone through fibers, which is called as Sharpie's fibers, right? So whenever this osteoid is laid along the capillary, is laid along the Sharpie's fiber, now this appears to you as this. What is this called? We all know this is called the sunburst appearance. So now you understood why it is called as sunburst appearance, right? So simply if you remember it as sunburst and Codman's, you might forget. But once you remember the osteoid, the osteosarcoma is an osteoid forming tumor, means it is a bone forming. That means on the HP biopsy, if you take this tumor and place it under the microscope after a certain staining procedure, you will see a bone is, so there are multiple bone. Hence, you can come to a conclusion that this is a bone forming, and it could be osteosarcoma, because the only malignant tumor which forms bone is your osteosarcoma. And the appearance of this is your sunburst appearance, because the osteoid is formed along the capillaries, along the Sharpie's fibers, giving you the presentation of the sunburst appearance. Then what do you mean by Codman's triangle? What is this Codman's triangle? So this Codman's triangle is nothing but there is an elevation of the periosteum. See, this is your periosteum, right? So there is a formation of the tumor, right? So this tumor, whenever it is formed, there is a slight elevation of which can be appreciated again by the bone form, right? So this is nothing but your Codman's triangle. So this appears as a triangle named by Codman's. So this is a Codman's triangle. So this is also a sunburst appear. Very, very important. Very, very important exam question. What is osteosarcoma findings? That is sunburst appearance and Codman's triangle, right? So these two are very, very important. And which gene it is associated with? Sometimes it is associated with P50. That is Li-Fraumeni syndrome. It is Li-Fraumeni syndrome. And it can also be seen in association with the retinoblastoma. So it is seen in with association with blastoma. Remember, P50 patient Li-Fraumeni syndrome, and usually the age group is 10 to 20 years. 10 to 20, right? So this is most commonly seen again around, so most in and around knee joint. It is osteosarcoma, right? So what is the treatment for this? The management is very, very management is, nowadays there is a neoadjuvant chemotherapy. So what do you mean by neoadjuvant chemotherapy? Neoadjuvant chemotherapy means this therapy which you give before surgery, that so that the, yes, you will downsize and downgrade staging. So whenever we see any tumor, we'll first stage it, right? We'll first stage it clinically and grade it pathologically. That means based upon biopsy, we stage it and grade it. Now, this neoadjuvant chemotherapy will cause downstaging and downgrading. That means, what does it mean? That means it is coming. So stage matlab kya hai? You will do what? You will first identify the lesion based upon its size, whether it is occupying particular nodes and all, no. So if it is if it was stage 3, when you give chemotherapy, it comes to stage 2. Similarly, downgrading means, so how do you grade? You grade 1, grade 2, grade 3 based upon the biopsy slide. So in that, you will mitosis present, something is present, and all, you give grades. So when you give chemotherapy, you can see that it has come down 1 grade. So it come from grade 3 to 2. That is called as downstaging and downgrading. So this is neoadjuvant chemotherapy. So it is chemo which is given before surgery, right? So that is neoadjuvant chemotherapy. Only adjuvant chemotherapy ka matlab, it is after surgery. So nowadays, this is called as NACT. NACT means neoadjuvant chemo. ET means therapy, right? That is after surgery. And what are the various surgeries? Important here. What are the various surgeries you do? So that depends upon, that again depends upon the tumor size, right? If the tumor size is so huge, you will remove the tumor and you will go for replacement. So what is the replacement? It is the total knee replacement. And after changing the entire knee, you might put various prostheses based upon your tumor excision, and then you will treat again with the chemotherapy. So that is the treatment for your osteosarcoma, right? So these all might be the questions like one liners. So they'll put up this x-ray, and they all know that you are very familiar with sunburst appearance. So now they will ask, which of the following is wrong about this condition. So it appears in 10 to 20. It is a bone forming tumor. It is a tumor which can be treated with chemotherapy, which can be treated with radiotherapy. So these are all the questions which they might asking. But remember, it cannot be treated by radiotherapy. Chemotherapy and surgery is the correct option there, right? And now the next one. So that is about your osteosarcoma. Now, what is this? Your favorite? This is your, yes, this is your Ewing's sarcoma. So what is Ewing's sarcoma? So Ewing sarcoma is such a group where the tumor cells are arising from the neuroectodermal, right? So this one you have to remember. Neuroectodermal, it belongs to PNET, right? So what is the main thing which you have to remember from ortho? Here, the periosteal reaction. So what are these periosteal reactions? So whenever there is a tumor which is occurring in the bone, the periosteum gets irritated and it reacts. What is the one reaction what the periosteum can do? The whole life of periosteum is only to form bone, right? So whenever it gets irritated, it forms bone. So how it forms bone is the various pattern which we see on the x-ray. So for example, now the periosteum is irritated and it is forming bone. So this osteoid is seen along the capillaries. So this is first appearance. Now here the periosteal is irritated, and now what it is doing, it is forming various layers of bone. Various layers of bone, and now this is appearing as a onion peel appearance. Your onion peel appearance, right? So onion peel appearance is condition. It is seen in the Ewing's sarcoma. So what are those important things which you have to remember about the Ewing's sarcoma? Very, very important. So Ewing's sarcoma, here what you have to remember about Ewing sarcoma is, again, this is also seen in age group of 10 to 20 years, right? And sometimes even less than 10 years. So first decade is most common, then second decade, that is less than 10 years. And whenever you see the patients with Ewing sarcoma, how do they present to you? Typically present with fever, right? They typically present with raised ESR, right? And when you see a patient complaining about pain, maybe let's take, because this is a diaphyseal tumor appearing in the diaphysis. So this diaphyseal tumor, you see, and usually they complained pain in the thigh. So they come with pain in the thigh and they present with fever with the raised ESR. Now, what do you think? Usually, what we think? We usually think it could be an, yes, this could be an infection. We can usually an in, but that is where you have to be very, very careful when you're dealing with the uh, less than less than 10 years of age group patients. There, what you do whenever you think it is infection, you will send it for culture and sensitivity. Right? So now what you have to remember is whenever you're sending for culture and sensitivity, also send it for biopsy. Usually all the tissue so has to be sent both to culture and sensitivity and to biopsy. Yes, they will mimic right? So whenever you send it for biopsy, what do you see on the biopsy? You see a pool of blue cells. So everything is blue and these are round blue color cells. Round blue cells, a sheet of round blue cells you see. And now, yes, CD99, MYC2 gene, these are all the signings which they get positive. And whenever you see such a condition where it is CD9 or MYC2 gene positive, this means we are dealing with what? We are dealing not with infection, but with Ewing's sarcoma. We are dealing with Ewing's sarcoma. And on the X-ray, when you see it clearly on the X-ray, you see this is onion peel appearance. What is the onion peel appearance? This is the layers of the periosteum. So this is represent onion, hence it is a onion peel, right? So that is about the Ewing sarcoma. You have to remember is the age, that is less than 10 years, that is first decade, and usually it can also be seen in 10 to 20 years also, and usually they mimic infection. And children especially, you have to deal with the infection or the tumor. First, always consider it as tumor, right? Because it is more dangerous. Always, whenever you're treating any patient, you have to always consider highest diagnosis, right? So always consider it as tumor, then send it for biopsy. Once you feel the biopsy is negative, yes, right? So how do you treat the Ewing sarcoma? Ewing sarcoma is supposed to be the most radiosensitive. That means on radiation, it melts like a snow. That is what it is described as. So this is supposed to be the most radiosensitive, and the terminology given to it as melts like snow on radiation. But we don't treat it with radiotherapy, because radiotherapies again are common in children. So usually we don't treat it with therapy, that is radiotherapy, but it is chemoresistance usually with, right? So that is the treatment for Ewing's sarcoma, right? And then what is the most common tumor in case of orthopedics? The most common bone tumor. I mean, the most common tumor, not specifically bone tumor, but the most common tumor. Answer would be in the age of 60 years and above. And the answer is yes, it is multiple. It is multiple. So whenever you see an age group of yeah, that very good. Bharat is very correct. So the most common tumor is usually the secondaries. But when I talk about the primary tumor, the most common malignant tumor is non or it not related to bone. The tumor, multiple myeloma. So this is very, very important in case of ortho. You have to remember, if they ask you something which is most common, something like that, you just specifically mention it as primary bone malignant tumor. If it is the word bone is mentioned, then it is osteosarcoma. If it is the tumor or the primary tumor most common, then you have to answer it as multiple myeloma. Or if this give what is the most common, it is the metastasis than any other tumor, right? So now let us understand the primary tumor. Let's take it as a primary tumor which is common, that is multiple myeloma. Hope you have learned so much of multiple myeloma in pathology and general medicine. Coming to the orthopedic point of view, what you have to do is just that, nothing else. just diagnose it as multiple myeloma. How do you diagnose it? Diagnosed with X-ray. So what is that? Punched out lesion. The punched out lesions on the skull, right? So these are very, very specific for multiple myeloma. The punched out lesions are seen on the skull. So this is nothing but multiple myeloma. And what is mainly the problem in multiple myeloma? So the plasma cells, right? The plasma cells, they become abnormal and they keep producing various immunoglobulins. And the rest is the story, you know, the most common immunoglobulin, the Ben Jones proteins, and what is the symptoms mainly they present with. This is very important, where you see the symptoms related to hypercalcemia. So whenever there is an increase of calcium symptom, so in this multiple myeloma, what you see, there is an increase calcium. So the symptoms of hypercalcemia, like constipation or various other features you see in case of your multiple myeloma. Yes, alkaline phosphatase will be normal in case of multiple myeloma. Yeah, normal AL is because there is nothing that with alkaline phosphatase there will be bone. It is a lytic lesion. What you have to remember, it is a lytic lesion. And what is, yeah, M spike is seen. That is seen. M spike, that is electrophoresis because of the IgM. Because of the IgM is, that is M, this M and M is not same. The IgM is the one which is the immunoglobulin, and M spike is different, right? And then what you have to remember is the punched out lesions is multiple myeloma. And the symptoms are mainly because of increased calcium, and because these immunoglobulins which are formed are not the normal immunoglobulins. Patients are usually, they are subjected to infection, so they have multiple infections. They may present with multiple infections, they may present with UTI. So usually these cases, no, these old cases, I mean, like older people more than 60 years, they simply come with the symptom of UTI, urinary tract infections, and that will be recurrent. And even how many ever antibiotics you put, they come with recurrence. And then now you have to suspect, whenever a patient of elderly female or a male presenting with multiple repeated infections with the loss of weight, loss of appetite, and other hypercalcemia, constipation, and this tingling and numbness in the hands, so you have to always evaluate for Ben Jones protein. And there might be a case of multiple myeloma, that be a secondaries also, right? So that is about multiple myeloma. Ma'am, is your session? Hopefully, I think it is enough, because I am covering the vast syllabus. I'm not just explaining the image, also covering the relevant point. So for ortho, probably it could be enough. Let's see. This time you follow the class and we will meet in the recall, and let us analyze how much it was helpful. Okay. So the one word I want to tell you about the metastasis here. So secondaries, somebody has raised the topic of secondaries, which is common in case of your tumor, in case of ortho. So the secondaries most common, what you have to remember is the first one, breast and prostate. So now let us assume that you have, yes, you're welcome, medical. So let us deal about this patient. So there is a patient, just listen, medical condition. So you will see a patient of 60 years, and now they have complained with the pain in the back. And in the back, usually what we do in ortho, we just write an X-ray, which is very, very an investigation department. So you have written the investigation, and here you see a lytic lesion, right? So breast, absolutely it is, right? So you see a lytic lesion. So whenever you see lytic lesion, especially in the vertebrae, that too, the dorsal vertebrae, lytic lesion, elderly female, have to always suspect this second piece could be the breast, could be from the breast. And next condition, this is a male patient, and now he has come with the blastic. So blastic means you can see there is a lot of bone formation in the. So whenever you see a blastic type of lesions in case of a male, obviously, and when there are certain symptoms, tumor symptoms like loss of appetite or loss of weight, then you have to always look for secondaries which might come from the prostate. Please remember, these are the two important areas. And one more interesting area is the lung. So lung is an interesting area again. So three important areas. So breast, prostate, lung, and then thyroid. And finally is your stomach. So these are the five areas where an orthopedic surgeon has to be familiar with. Secondary. So it could be from breast, most importantly from females, prostate, male, whenever you're attending a male patient, and not to forget the lung, because usually we are in this we will be in this thought of blastic and lytic, but please remember mixed also. There could be a scenario where there could be a blastic lesion and a lytic lesion, which is called as a mixed lesion, and this is of lung, right? So this is about the secondary. So secondaries, usually if they ask, they will put up a patient with breast or the patient with. And now if they want to give something like the bouncers, so this time they can put up with the mixed lesions. Please don't forget your lung. Okay, now what is this? This is a very simple thing, but we usually don't see, or we usually don't remember. So this is nothing but a condition of physis, right? And this is a non-ossifying fibroma. So non-ossifying fibroma is nothing but just an incidental finding, right? Just an incidental finding, nothing to worry about it, and it will heal by itself. So this is a non-ossifying usually seen, yeah, and sometimes it is an incidental finding, right? So that is about the thing. So this could be put up as an image, and they can ask the name of that particular tube. So it is non-ossifying fibroma, right? And then what is this? So here what you see is the corduroy appearance or the jail bar appearance in case of your CT scan, and that too in the sagittal view. So you know what is sagittal and coronal, right? So this is your sagittal view. So whenever we see this sagittal view, there is a corduroy appearance and then there is an jail bar appearance. So what you, so one incidental finding. So this is also an incidental finding, and this is called as hemangioma. So whenever you read the MRIs in your OPD, so you tend to read MRIs, right? You tend to patients, and in that MRIs, usually they give an incidental finding that is hemangioma. So usually hemangioma, we don't treat anything. Just again an instant. But why are we worried? We are worried only about the MCQ. So that is the open, what is jail bar appearance, and then the corduroy appearance. So what is a corduroy? A corduroy is nothing but a type of variety cloth where you see all these lines are present. That is your corduroy panta or corduroy sheds we have. So that is a type of cloth. And what is jail bar? You know the jail, their bars are there, no? So that is the jail bar appearance. And then if you take a axial section of, and I mean if you cut the patient like this, like this. So now we are cutting the patient sagittal like this, right? So now we are cutting up and down. So this here, what you see? Yes, you see the polka dot appearance. So what is polka dot? Go back in your retro themes. You have this cloth, right, where joints where with all dots, plain sari with all dots. So these dots are called the polka dot. On the axial section, this polka dot sign, and again it is an indication of hemangioma, right? So these are the two important things you have to remember: the jail bar appearance, the corduroy appearance, and the polka dot in case of a CT scan, that is axial cut, right? So this is about the various tumorous conditions. Remember in case of your uh, uh, FMGE exam, right? So I hope you have covered the tumors, right? So these are the various important tumors. I mean, you have to remember all the one-liners, right? So the jail bar appearance is the polka dot appearance is years of age group, right? So these are all again the GCT seen in the epiphysis, right? And these are all the one-liners also you have covered. Okay, I hope that finished the tumors. Next, going to the most important topic. This topic you have to listen and just listen. Don't write anything. Just I will ask you, and then we right. So the first one, there are three important nerves which you have to remember. So let us make a chart of it. So the first thing what you have to remember is there are three important nerves. So one is your median nerve, ulnar nerve, and the radial nerve. So nothing to worry about it. Very, very easy. Just concentrate. So first thing I will teach you about the radial nerve. What you have to remember about the radial nerve is it supplies all the extensors. One liner. Finish. All the extensors. Okay. Before that, all these three nerves supply the upper limb, right? That is clear for you, right? So now we are the upper limb. Okay, so all the extensors of the arm and the forearm are supplied by even the wrist and everything, your radial nerve. That you have to make it very, very clear. Utkarsh, now also the voice is breaking. Just just then I've just texted the tech team. They will call me back. Voice break. Till then, I'll just continue. Okay, now we are dealing with the upper limb nerves, right? So there are three important nerves which you have to remember. I've told you the median nerve, the ulnar nerve, and the radial nerve. These three you have to remember, right? And coming to the radial nerve, what you have to remember is very easy that it is supplying all the extensors. So it supplies all the extensors. And then now coming to the median and the ulnar nerve. So the median and the ulnar nerve, it supplies all the flexors. As we know, we have only extensors and we have flexors. Now is it now? Yes. So now the extensors are supplied by the radial nerve and the flexors are supplied by the median and the ulnar nerve. So what you have to remember in this is the median nerve. If you see the median nerve, if you see, just remember whatever we are talking about the median nerve, it is related to these three fingers. That means the thumb, the index, and the middle finger. So the thumb, index, and the middle is your median nerve, and anything which is related to the little finger and the ring finger is your ulnar nerve. So ring and the little finger, right? And now what you have to remember is the muscle. So whenever you read about the muscles, you also cover the anatomy part of it, right? So we are discussing in integration with the anatomy. Now let us learn about the muscles. So coming to the muscles, what are the muscles which are supplied by the median nerve? So median nerve supplies all the muscles. So most of the flexors, if you remember the names of the flexors, most of the flexors are supplied by the median nerve, except, so we have to leave the nerve, muscles which are on the ulnar end, right? So we are leaving two important muscles. So one is flexor carpi ulnaris and medial half of flexor digitum profundus. These two you have to remember. So median nerve supply all the flexors except flexor carpi ulnaris. As the ulnar nerve, ulnaris has to go to flexor carpi ulnaris. Then medial half of flexor digitorium profundus. Because this digitorium profundus supplies the, this medial half supplies the two important fingers. I told you already the ring and the little are for ulnar. So these muscles are going. Okay. And now as you know, this median nerve is called as the laborer's nerve. Why it is called as the laborer's nerve? Because it is mainly related to the forearm flex, forearm flexors, and in the hand, and the ulnar nerve is called as the musician's hand, right? So whenever it is called as musician's nerve, if you remember, the musicians now they work only with their hand, the muscles of the hand. So most of the intrinsic muscles. So what do you mean by intrinsic muscles? The muscles which take their origin in the hand and they insert on the hand. These are called as the intrinsic muscles. So these hand muscles are supplied by your ulnar nerve. So what are those hand muscles? If you remember, yes, the dorsal interossei, palmar interossei, hypothenar, third and fourth lumbrical, right? Nothing by heart. Is everything is connected. Just remember, ulnar supplies, adductor pollicis. Yeah, I'm coming for the exceptions. So now here, this musician's nerve, as I've told you, so these are the hand muscles which are supplied by the ulnar nerve. So the dorsal interossei, the palmar interossei, all the hypothenar muscles, and the third and fourth lumbrical. So when I write the third and fourth lumbrical, that means the median nerve supplies the first and the second lumbrical, right? And now in the hand, it supplies what? It supplies the thenar, supplies the thenar muscle. So these are all the blood, all the nerve supply. So flexors, that is the median nerve, is supplying few muscles. As we know, the most of the flexors except FCU and half of P. And now coming to the hand muscles. Ulnar nerve supplies most of the hand muscles, right? Then the median nerve supplies which hand muscles? The thenar muscles, a group of muscles, and the first and lumbrical, right? And now what is important for us is, again, yes, whatever is the exception is important for us. Now in the thenar group of muscles, one muscle, that is adductor pollicis. Pollicis ka matlab, pollicis is that which is related to thumb. So this adductor pollicis is one muscle which is led by your ulnar nerve. This, remember, because there are various tests which are related to this particular adductor pollicis, right? So this much is enough. So if you remember this, nerve injuries is a cakewalk for you, right? Now coming back to our various tests which are easy to remember now. So first we will deal with the radial nerve, right? So radial nerve, as I've told you, it supplies all the extensors. And what is the important thing which you have to remember here? This is, remember that it is the nerve which is damaged in the Saturday night palsy. So what is a Saturday night palsy? So this is a picture of a Saturday night palsy. So you all know what happens in the Saturday night in with your friends, right? Not with you, but your friends. What usually they do? They do binge drinking, right? So they do binge drinking. So whenever they drink and whenever they sit in this position, might cause pressure over the axilla, and this will damage your radial nerve. Now tell me, what is this example for based upon the type of nerve injury? Very, very important. The concept comes here. So this is an example for neuropraxia. So what do you mean by neuropraxia? So you all know that the nerve, right? Nerve. So basically, if you take a nerve, it is covered by certain layers of, yes, praxia, correct. So it is covered by, so this is your axon, and now we have what is called as, so here what happens is now the axon is covered by a myelin sheath. So this is your myelin sheath. The axon covered by the, right? And there are three important layers which you have to remember. So the first one is your endonucleum. Endo means side. And then it is covered by your perineum and then your epineum. So these are the three layers, right? So these are the three layers three layers of the nerve injury. So whenever there is a damage to the endoneurium, still the nerve can repair itself. But if it damages the peri and epineurium, it cannot repair by itself. You have to repair it surgically, cannot repair it by itself. So still with the endoneurium, it is, but if it is just a myelin sheath which is damaged or just a conduction block. What do you mean by conduction block? That means the axoplasm is not flowing. No, there is no injury as such the nerve, but there is a stop. There is a block to the flow of the axoplasm. As you all know, there is a signal which is reaching here, and now this signal, this particular signal has to pass through the axon, and now it reaches the terminals, right? So what do you mean by this? What do you mean by this conduction block? That means there is a physiological block. Yes, Bharat, that is correct. There is a physiological block to the axoplasm, which is called as the neuropraxia. So why am I discussing so much about the layers and I'm telling it as neuropraxia? Because you have to reassure the patient that they would be 100% recovery. 100% recovery. But why actually they are worried? They are worried with this condition. Whenever there is a damage to the radial nerve, there is wrist drop. So what is wrist drop? Loss of extension. So there will be a loss of extension. So this is loss of extension. That means the wrist just drops like this because the patient cannot extend. So this is called the wrist drop, usually the radial nerve palsy, and this is called as the Saturday nerve palsy, which is because of the binge drinking and compression over the axilla, which will cause the neuropraxial injury to the radial nerve. Very, very important question. But nowadays, the shift of this particular concept towards this fracture. They have now left the Saturday night palsy, probably stop that drinking thing. Now what is the present scenario? Now how are they asking, framing the question? So now they are putting up this particular fracture. So this fracture, if you see, it is exactly at the junction of middle and the distal. So whenever you see a diaphysis, you can divide it into proximal, middle and distal. So this particular fracture is exactly at this particular area. So whenever there is this fracture, if you go back to your anatomy, you can see the radial nerve is passing, and now from the medial, it comes to piercing the lateral intermuscular septum. It comes to the lateral side while crossing this particular area, while crossing from the medial towards the lateral side. And now what happens is this radial nerve is very tightly adhered. Tightly adhered. That means it is fixed to that particular bone. Tightly adhered means it is fixed to that particular bone, means it cannot move. So whenever something cannot move, so if there is a fracture, this nerve gets compressed between the fracture, right? So now this produces what is called again as, so radial nerve is getting irritated at that particular junction, up again extension, and this is also an example of neuropraxia if it is a closed injury. If it is a closed injury, neuropraxia. Neuropraxia means it is causing of the nerve, and the nerve is getting irritated, causing block of the flow of the axoplasm. This is just a block of the axoplasm, right? Bharat, I just want to correct you. This is physiological block. Usually, physiological, what we say, what we tend to try to tell is this is done by the body by itself. So there is nothing pathology happening, and then body simply tries to do that because it doesn't want to act in that particular way. But usually what is neuropraxia is certain damage which is caused to the nerve, and now because of this damage, because of the neural irritation, there is a conduction. This is considered as the pathological block only of the axon. Okay? So that is about the neuropraxia. And then what is axonotemesis? So what is axonotemesis? Axonotemesis is nothing but there is damage to the two layers as we have mentioned, that is the epithelium and the, okay, whenever it is neurotemesis, it is complete damage. So complete damage of the layers. So all the layers, including the epithelium, is here there is damage to the perineurium. But this is what is called as the Sedan's classification. So Sedan's classification is three types. So it is neuropraxia, axonotemesis, and neurotemesis, right? But Sunderland's classification, there is one more classification which is called as the Sunderland's classification, where there are types. So here they have classically given it as, so the first one is just a conduction block, the second one is damage to the axon, the third one is damage to the endoneurium, the fourth one is damage to the perineurium, one is damage to the epineurium. So based upon this Sedan's and Sunderland's classification, you can grade the nerve injury. So coming back to your Saturday nerve palsy and your closed Holstein-Lewis fracture. So I have forgot to tell you the name. This is nothing but your Holstein-Lewis fracture, where there is a fracture of the humerus. So this is the fracture of the humerus, where now this particular fracture has occurred in the humerus, especially the junction of the middle and the distal third and the distal third, resulting in palsy of the radial nerve, which is resulting in wrist drop. Right. So this again we have even learned the classifications, the sedans and plants. The sedans are three types: neuropraxia, axonotemesis, neurotemesis, and then there is a Sunderland's classification dividing into five types. And now, what is the treatment for this wrist drop? So this wrist drop can be treated conservatively because we are still thinking as a neuropraxia, right? So whenever we go for a conservative treatment, so how do we treat it? We just treat splints. So how are the splints used? There are two types of splints. So one is a static, the second one is the dynamic. So the first one is static. This is a static splint. This is the dynamic splint. So the name of this is cock-up. Of this is the cock-up. There is a static cock-up splint and a dynamic cock-up splint, and this cock-up splint is mainly used for your radial nerve injury, which is resulting in wrist drop. So what does this actually do? So why you actually put up this splint? Are they repairing the nerves, or are they repairing your muscles, or what is happening? So why actually we are using this splint? So whenever there is an injury to the nerve, what happens is the muscle goes into atrophy, right? So doesn't have understood. What happens is tendons. We are most worried about the tendons going to atrophy. The tendons they go into fractures, right? If you don't put them in the they will position. So to prevent this contact, we give this splints. So this cock-up splint is mainly putting the hand in the function. That means there is a radial nerve actually like this. Now what you're doing, you're giving tendons the work to put them in the norm. They put like this continuously. So now they put in the static cock-ups, and then over a period you give work to this tendon that they can't contract relaxing, and once the nerve gets back its position, one now the nerve recovers from its trauma, now the tendons are ready to act. So actually with this we are protecting the tendons. So whenever there are springs which are attached on the dorsal aspect and causing the fingers to do flexion and extension with the help of spring mechanism called as a dynamic cock-up, where there is no spring, just they are in a resting position called a static cock-up spring. That is the basic difference, right? So that is all about the radial nerve. Now coming to the most important topic, your median nerve. So I've already told you the median nerve is related to thumb, the index, and the middle finger. So this is your median nerve, and whatever you see about the median nerve is always related to your mainly. So if you see a ape thumb deformity, now tell which nerve called. So ape thumb is mainly related to your median nerve. So what is an ape thumb deformity? Is it so? Am I causing so much of trouble with the voice? And I don't problem because for this, I don't know. Now is it fine? Okay, I have reported again to the people who are looking after this. Is it fine now? Okay. So now we are dealing about the median nerve. I have told you that something related to your thumb or the index finger or the middle finger is related to your median nerve. So coming to various things which are seen with the median nerve palsy, the first thing what you have to remember is it close. Okay, the first thing what you have to remember is about the ape thumb deformity. So coming to the ape thumb deformity, here what happens is when you go back in the history, the apes, we have evolved from the apes, right? So here the thumb is in line with the other fingers. Now what happened? The thumb has become perpendicular. In as we evolved as humans, the thumb has become perpendicular to other fingers. Now with this median of palsy, the thumb is again going back in line with the other fingers, which is called as the ape thumb deformity. This is called as the ape thumb deformity, right? And now the next one is pen test. Again, test for the thumb. So now we are going to put the pen and now we are going to test for the opponent's pollicis or abductor pollicis, right? So whenever you are able to abduct it and touch the pen, this is called as the pen test. Again, if you see, it is the involvement of the thumb. The testing of the thumb is called as the pen test. Now again, the next one. This is what? It's called as the pointing index. So this is called as the pointing index. Why there is a pointing index? So this is again related to your index finger. If you remember, the thumb and the index is related to your median nerve. So in case of your median nerve palsy, what happens in case of your median nerve palsy? The flexors are at loss, right? So there is a palsy of for the flexors, especially the index finger, because these two fingers are again supplied by the digitorium profundus. So they now they will flex happily. And the second one has then interesting thing that it is related with the lumbricals, right? So the index finger, the index finger is the only one finger which is purely supplied by the median nerve flexor. So when you try to close all the fingers or try to create a clenching fist like this, so here what happens is whichever hand the median nerve is damaged, you can see that the index finger is unable to flex completely, and this is called as a pointing index. And similarly, if you see, as I've told you, so these two completely flex, and this will flex only little bit because of some action from the other two lumbricals which are there. But the pointing index is completely not flexing. So this is something which is called the Pope's sign or the benediction sign. The Pope's sign or the benediction sign. The Pope's sign or the benediction. Right? So that is also seen in case of your. Yes, this pointing index is also called as the Oshner clap deformity. Called as the Oshner clasp deformity. Very good. That is called the Oshner's clap deformity. Very good. And now this is called the Pope sign or the benediction sign. And then what we have this is the what is this? This is the anterior interosseous nerve. What is the anterior interosseous nerve? This is nothing but your branch of the median nerve. So this is a branch of the median nerve, the anterior interosseous nerve. And what is the sign? The beautiful sign. Yes, this is the OK sign. So this is the OK sign, and whenever person is unable to do an OK sign properly, So this is a complete O should come. If it is something like this oval, then this is a weak okay sign. So this is a weak okay sign which is seen in case of AIN palsy. So anterior introitious nerve palsy is called the okay sign, right? So this is about the median nerve palsy. So ape thumb deformity, the pen test, the pointing index or the Oshner's collapse deformity, and we have the Pope sign or the benediction sign, or we have the okay sign. So we can first pehle to you concentrate on these images. At the end of the class, we will discuss whether these images are enough or we have to do some more. Okay. So that is about the median nerve. We completed the radial nerve and we are left out with only one interesting nerve, that is your ulnar nerve. So why I have told this as interesting ulnar nerve? Because this ulnar nerve is related to little finger and your ring finger, where there is an important condition which is called as the claw hand. So what is this claw hand? What is clawing? So again, go back to the basics. I have told you the ulnar nerve supplies what? It supplies the lumbric, right? So it supplies the lumbric. So what is the action of the lumbrical? What is the action of lumbricals? Yes, thanks for correcting me, Bharat. So this is a partial claw hand, correct. So where do you see a complete claw hand then? So complete claw hand is seen in, yes, I want you all to answer. The complete claw hand is seen in both median and the ulnar nerve palsy. So there will be a complete clawing like this. So this is a partial claw hand. So why is this clawing happening? Because there is a loss of lumbrical action. So lumbricals action is, they cause what? They cause extension at the MCP and flexion at the IP, which is used for your good handwriting. So if you want to have a good handwriting, you have to train your lumbricals, where they cause what? Extension of the extension of the IP and flexion of the MC, right? So this is what is the lumbrical action. Now what is clawing? Clawing is exactly opposite to it, where you see there is a hyperextension of the MP and flexion of the IP joint. So that is clawing, where you see hyperextension of MP and flexion of the IP. Right? So this is what is called the clawing, right? So this is the claw hand. And now what is this test? This test is called the card test. So what is this card test? If you go back and remember that the hand muscle, where they are involving the dorsal interosseous and the palmar interosseous. Have to remember the dorsal interosseous is dab, the palmar interosseous is pad, right? So dorsal interosseous, they cause abduction. Palmar interosseous, they cause adduction. Now what is this card testing for? The card test is for what? They do adduction testing, right? So they're testing for adductors, that is palmar interosseous. Now they are testing for palmar interosseous muscle, right? So that is the card test, where you hold the card and now you test for your adduction of the finger. So that is your card test. And now what is this book test? So they are showing us a book and now they're asking you which test is this and for what. If you go back and remember, I have told you there is a one important muscle which is called as your adductor pollicis, which is supplied by your ulnar nerve, right? So this is supplied by your ulnar nerve, that is your adductor pollicis. And now based upon this information, now we are what actually we are asking the patient to do, we are asking the patient to hold your book. So this is the book. So I'll show you like this. So this is the book, we are trying to hold it, right? And now when you're trying to hold, what do you do? Again, you do adduction of the thumb. And now there is a ulnar nerve palsy where your adductor pollicis is not working. Now what you do? You will leave the book? No, we will not leave the book. What we'll do? We'll use the flexor muscles and then we'll try to hold the book. Because this usage of the flexor muscle is nothing but this Fromen's sign. So this is called your Fromen's, right? So this is called your Fromen's sign. So this is your Froment sign. So Froment sign is nothing but this is the flexors which are being used instead of the adductors. So that is your book test, and this is a Froment sign. And please remember the book test, even though you're testing the number, it is the ulnar nerve, because it is the muscle. What we're testing is the adductor pollicis, and we already know that this adductor pollicis or ulnar nerve. So that is about the test. And what is this? So we know for the radial nerve, it is the cock-up splint, and for the ulnar nerve, this is your knuckle bender splint. So this is your knuckle bender splint, right? So again, as I've told you, what is the splint for? You put the hand in the functional position, where again you're causing the flexion of your MCP, right? And extension of your IP, as the action of the lumbricals is the same thing, right? So this is called the knuckle blender splint. Simply remember this as used in case of your ulnar nerve. And radial nerve, what is the splint? It is the cock-up splint. Cock-up splint is the one which is used in the radial nerve. So that is it about the nerve injury. So we have median nerve, ulnar, and the radial nerve, and the various tests and splints which are with it, right? And now I'm going back to one important thing. What is this sign called? So this is called the Tinel's sign. So this is called the Tinel's sign. So what is Tinel's sign? So as you remember, we have told you that in case of neuropraxia, and there is axonotmesis and neurotemesis, right? So you have to remember that you have to always tell the patient what is the prognosis. You have to always tell the prognosis, right? In the prognosis, what you say, whether there will be a recovery of the or not. So for example, you just imagine that there is a patient of 40 years old, binge drinking. Saturday night he has come with wrist trauma. Now what you do, what do you tell the patient? You tell the patient that because this is of neuropraxia, which is just a conduction block, this will recover completely. That is 100% recovery will be there. But now, 2 weeks later, again, that patient will come to you and ask, ma'am, that ma'am or sir, that you have told me that there will be recovery. But now 2 weeks, it has been 2 weeks, right? So can you please check whether it is recovering or it is not? Then what you do? What is the test you? So there we use this Tinel's, right? So what is this actually the Tinel sign is? So if you remember, if just imagine this as the nerve, and now there is a damage to this. So there is a damage to this. So whenever there is a damage to this nerve repairs itself by a thing which is called as a Wallerian degeneration. Okay, this is called as Wallerian degeneration. So what is this Wallerian degeneration? If you go back to the fractures, fractures, if you see, there will be a fracture and then there will be 5 stages where the fracture heals, right? So fracture hematoma, then granulation tissue, then soft callus, hard callus, and finally remodel. Similarly, for the nerve, whenever the nerve breaks, there are certain things also happening there. So this pathology, whatever it is happening for the regeneration of the nerve, is as Wallerian. That means all the fibrils, all the nerve tissue will be eaten up by the fibrocytes, and there will be formation of the new fibers in place of the old fiber. So this is the Wallerian degeneration. So whenever there is a regeneration of the nerve, so if you imagine the nerve is damaged here in this particular area, so there is a damage of the nerve here. So nerve has been damaged here. So here what happens is the two ends will be there, no, proximal ends and the distal ends. Now what happens is this the proximal ends will try to form and they get connected with the distal end. So while this formation is happening, and now you want to test whether this is nerve is recovering or not, then you go for this test which is called as the Tinel sign, which will help in recovery of the nerve. So analysis of the nerve recovery, or will tell you about the prognosis. So we all know that in neuropraxia there is a conduction block. So how does this conduction block come back? So it will regenerate as centimeter, 1 mm per day. It will grow as 1 mm per day. So based upon this Tinel sign, so how do you do the Tinel sign? So now you place the patient's hand like this, and now I've told you, you have to always, the nerve always grows from proximal to distal like this. And now you have to identify whether it is recovering or not. So how do you test? So now if there is a damage here, the nerve will come progress like this. So you will do Tinel sign from distal to proximal. So if you feel a tingling sensation by tapping here like this, that means the progression has. And now you send back the patient and call him back after 2 weeks or 3 weeks. And now again you do the Tinel sign. And now this time you get the Tinel sign has come up to here. Means there is a recovery this level to this level. That means there is a nerve progression. So axoplasm is from proximal to the distal. But the Tinel sign is done from distal to proximal. That you have to understand. So this is about the Tinel sign. This may appear too much to you, but sometimes they're asking clinical questions. So that is why I've explained you. Well, if you don't understand also, that is fine. Just remember the Tinel sign will tell you the prognosis of the nerve recovery, especially positive in case of apraxia and axonotmesis. In neurotemesis, there is no Tinel sign. This Tinel sign negative, right? Yes, progressive Tinel is seen in axonotmesis and neuropraxia. Very good. That is good. So Tinel sign is seen in both. That is the thing. And next, what is this? So this is purely the sensory distribution, right? So what you have to remember about this, I have told you the 3.5 fingers always belong to the median nerve, and the 1.5 finger belongs to your ulnar nerve, and then the thumb is your radial nerve, right? So based upon that, you can just remember. So the 3.5 is blue color, that is your median nerve, where you see, right? And now the green is your ulnar nerve, that is your 1.5 finger. This is your ulnar nerve, and the radius is on the dorsal aspect of the thumb. Radial nerve, right? So that is the sensory distribution. And now if you remember the autonomous zone also, similarly, the tip of the index finger, is your median nerve. This is autonomous. Tip of the index finger. And ulnar is your tip of the little, and radial is the tip, first dorsal web space. The tip, but the dorsal web. And this particular area. This is the first dorsal web space that is particularly autonomous radial nerve, and the tip of the index finger is for your median nerve, and tip of the middle little finger is for your ulnar nerve. So that's it about the sensory, and that's it about your nerve injuries. Very, very important, right? And now coming to other tests. So what is this test depicts? So here you can see that the finger or the thumb is over your, yes, this is your lateral epicondyle. They are compressing it over the lateral epicondyle, and now they are trying to do the wrist extension, right? So what is this for? The wrist extension, you see the test is for your, this test is for your, this is called the Cosen's test, and this is for your tennis elbow, right? So what is tennis elbow? Tennis elbow is nothing but your, yes, tennis elbow is nothing but your lateral epicondylitis. That means what is itis? Lateral epicondylitis, lateral epicondyle inflammation. So what is the extensor, lateral epicondyle is for? It is a common extensor origin. This is the CEO, right? So the common extensor origin, and whenever there is an inflammation of this epicondyle, usually it irritates the extensor carpi radialis breve, right? So this particular tendon gets irritated, and this is nothing but your tennis elbow, that is lateral epicondylitis. Similarly, what is medial epicondylitis? Medial is nothing but your golfer's elbow. So reverse Cosen test is done for. So you do a reverse Cosen's for your medial epicondylitis. That is your common flexor origin. That is your CFO, right? CEO and CFO, right? So that is about your test. And this is what? What is this test? This is nothing but your Finkelstein's test. What is Finkelstein test for? So this Finkelstein test is nothing but for your de Quervain's Tenosynovitis. Lecurvens tenosynovitis. And what is involved in it? The involvement of the first compartment extensor tendon, right? The first compartment extensor tendon. What are those? APL and EP. That is abductor pollicis longus and extensor pollicis brevis, the first compartment tendons, whenever they are involved, they cause this condition which is called as decurvens tenosynovitis. So what will happen actually? So this APL and EPB are now arranged in a compartment. So there will be tenosynovitis. That means this is a tissue. This is a layer which is covering the tendon, right? So there is a covering over the tendon, and now this tendon sheath which is there, it is usually helping the tendon to glide, right? So the tendon keeps moving in and out towards it, right, to tendon sheath. So whenever there is an inflammation of tendon sheath, the tendons can't move freely inside. Hence this results in pain over the wrist. And whenever you will do this test, so now what you have to do, you have to put the thumb inside, then close and then extend it. So this is the action of APL EPB. So whenever you're doing an extension like this, that means it gets stretched and now you will have your pain. So this is called the Finkelstein's test. And for the Kurvain's tenosynovitis, please remember APL and EPP are the two important tendons which gets damaged here, right? So this is the Finkelstein's test. And now coming to this. So this is the recent image which was put up in the exam. So what is this image talking about? So already as the labelings are there, they have put you an X-ray giving you a fracture fibula. So whenever there is a fracture fibula, especially in the proximal end, that is neck of the fibula is fractured, which results in what is called as damage to the common peroneal nerve. So this common peroneal nerve usually takes a turn over the neck of the fibula. Going back to your anatomy, so whenever there is a fracture or whenever there is a damage to this particular neck of the fibula, it causes damage to the CPN, that is common peroneal nerve. And when it happens, it results in what? It results in what? It results in your foot drop. It results in your foot drop. Similarly to the wrist drop. So what is foot drop? How do you treat it? So this is your foot drop, right? So this is your foot drop splint. So this is nothing but again your orthotics. So orthotics is nothing but a supplement for your part. Now again, this foot drop is again putting this ankle and the foot in the functional position. If you see, it is in functional position. Otherwise, the foot has to go down like this. And this foot which is dropped is put in functional position, and this is maintained by your foot drop splint. And what is the gait which you see in high stepping gait? The gait which is seen here is the high stepping. So this is the high stepping gait. So the question usually what the frame is. So and so person of age some 35 years has come with the fracture over proximal end of the fibula and now appears to have a high stepping gait. What would be the reason? Then is mainly damage the CPN. Or they can put it in the reverse way. They can give you a image or a X-ray of the fibula fracture and they can ask you which gait is expected in so condition. It is a circumduction gait or it is a Trendelenburg gait or it is a antalgic gait or it is a high stepping gait. So what would be the answer? The answer would be your high stepping gait. So that is the answer. That is the CPN will result in high stepping gait. Next, what is this? So what is this patch of thing what they're testing about? This test is nothing but for your axillary nerve damage. So axillary nerve damage, where you see this axillary nerve damage is seen in your shoulder dislocation or in case of your proximal humerus fractures. So these are the condition where there is a damage to the axillary nerve. So what does this axillary nerve do? It supplies the deltoid, it supplies the is what does the deltoid do? The action of the deltoid is abduction. The action of this is external rotation. Now, whenever there is an axillary nerve palsy, what happens is there will be loss of the abduction. patient cannot lift his hand up. So this is abduction, right? So he cannot do the abduction. And the sensory distribution of this is a patch over the deltoid, which is called as the regimental badge area. So this is called as the regimental badge area. So this particular patch of the area over the deltoid is called regimental badge area, and usually becomes hypoesthetic or anesthetic in case of axillary nerve palsy. The regimental patch, right? In case of your axillary nerve dislocation. Now coming to the brachial plexus injury. So brachial plexus, what you have to remember, there are two important things which you have to remember, right? So there is a damage to the upper trunk, and then there is a damage to your lower trunk. I think you all are familiar with your upper and the lower trunks, right? So now what is this? Upper trunk damage is called as your Erb's palsy, and lower trunk is your Klumpke's palsy, right? So it is easy. Upper trunk is mainly C5 and C6. This is mainly C7 and C8. Right? So whenever there is a damage to the lower trunk, that is Klumpke's palsy, as we have already discussed, there is a C7, C8, that is the median and the ulnar nerve gets damaged, which results in your complete claw hand. Right? Can see which one is your clump case. So this is your clump case, where you can see there is a complete clawing of the hand. So that is clump case, complete clawing of the hand, where there is a damage both medial and the ulnar nerve. Right? And now coming to the Erb's palsy. Erb's palsy, where there is C5 and C6, that is the upper trunk. As we already discussed, there is a damage to your axillary nerve. Hence, if you see this particular, there is an adduction of the forearm plus external rotation. So because there is a loss of abduction and external rotation, because there is a damage to the axillary nerve. And then if you see the forearm where which nerve is damaged, the musculocutaneous, the flexors. So now what happened? It has gone into extension of the elbow with the pronation, right? Extension with the pronation. So it is adduction, internal rotation. So there is adduction, internal rotation, and then there is a pronation, and it is extension of the elbow, which is similarly like the policeman tip. It is similar like the policeman's tip. That is mainly seen in case of your upper trunk palsy, which is the Erb's palsy, because there is a damage to the axillary nerve where there is adduction, rotation is lost, right? Sorry, abduction and external rotation is lost, which is resulting in adduction of the forearm and internal rotation of the in the arm. Sorry, adduction and internal rotation of the arm. In the forearm, it is the extension of the elbow with the pronation of the forearm, right? So this is the Erb's palsy. And now coming to Klumpke's palsy, it is a lower trunk where there is a C8 and T1 which is damaged, resulting in the complete. And now, whenever there is a damage to the brachial plexus, there is a one important splint which you have to remember, which is called as the aeroplane splint. If you can see, the functional position is again, there is an abduction plus external rotation with the elbow in, right? So this is how you have to put this splint in. Always put the splints or cast in the functional position. Brachial plexus, for the hand, the functional position is always abduction and external rotation with elbow flexion. That is the aeroplane splint used for your brachial plexus, right? That completes the nerve injuries. Very, very important. Now coming to the joints. So now what is this X-ray about? So when you want to read about the joints, you have to read about two important things. One is the inflammation. Second one is your degenerative condition. So here what is mainly important is your X-ray, right? OA. They mainly come with the osteoarthritis. What they usually come with? They come with pain, right? So both they come with pain in the joints. So both the questions, they start with pain in joints, especially the knee joint, right? But for inflammation, what is important? Inflammation, what is important? So inflammation, what is important for us is they complained with polyarthralgia. So, if you remember, the osteoarthritis, mainly degeneration, right? What is degeneration? That means wear and tear, excessive usage. For example, you bought a pair of shoes. You completely keep wearing those shoes daily, 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 daily. Over 3 months or 4 months, they become completely torn, right? So that is the degeneration. So that is the degeneration. So we are using the knee joint is bearing our weight, especially medial compartment. The medial compartment is taking a lot of weight on a day-to-day basis. In that, you walk, you jump, you skip, you hop, you climb. So all those actions are managed by the medial compartment over a period of time, that is more than 50 years. What happens is the medial meniscus get damaged. So if you remember, always we this shock absorbers in between, right? So whenever you put any two things, any two like things, you put a shock absorber between them, right? So there will be a lot of friction if the same surface slide each. Similarly with the bones too not move upon each shock absorber. And now here it is the medial meniscus. Now what happens? The medial meniscus gets torn over a period of time. And now what happens? Whenever there is a bone in the medial meniscus, the subchondral gets exposed. And whenever this subchondral exposed, the fluid which is present gets seeps the subchondral bone, which is resulting in what is called as the subchondral cyst. It is called as subchondral cyst. So whenever you see it's arthritis because there is a meniscus, and now this is going into, and once the subchondral bone subchondral cyst are formed, still you're neglecting, and now what happens? The bone becomes so weak, it goes into deform. That means the medial compartment completely it gets closer, and now there will be opening up of the lateral compartment to adjust the biomechanics. So that is why you see there is a complete damage to the medial compartment in case of your osteoarthritis when compared to your lateral compartment, right? And now coming to the inflammatory, that is rheumatoid arthritis. In rheumatoid arthritis, what happens? This is nothing but an autoimmune condition. Here, what happens is nothing to do with the wear and tear. Since younger age, the body defense mechanism is defective. That means there are some antigens which have been identified as a foreign antigens, and now body reacts with it and it forms antibodies, and these antibodies now go and they damage the synovium of the joints, especially all the synovial joints will be affected, and these antibodies are called the RA factor. So these RA factor is nothing but the antibody which is detected in the body. And now this antibody goes and damages the synovium. So this is synovial inflammation. What happens is synovium is completely present around the joint, right? So the synovium is nothing but it is a capsule, it is a tissue which is covering the joint. Now this synovium gets irritated. So whenever it is irritating, the one thing what it does is it produces synovial fluid like the periosteum, which bone, the synovium produces synovial fluid. Excess of synovium. Now, what happens over a period of time after the synovium is completely getting into contractures, it also damages the cartilage. It also damages the cartilage. So this damage of the cartilage is equal on both medial and the lateral side. There is nothing to do with the weight. Here in the osteoarthritis, it was something. There is a weight which is causing damage to the medial. Here, this is equal. The synovium is on the medial, on the this gets inflamed. Now it damages cartilage and now it damages the bone. Ultimately, this also results in or ultimately it also result in deformity, right? So, but the most interesting is the involvement of the joint arthritis, such as most commonly the MC joint, wrist joint, and the proximal interval joint. These are the three important joints which are involved in your rheumatoid arthritis. In case of your osteoarthritis also, there is an involvement of PIP and the DIP. There is nothing that the only rheumatoid has joints, but this osteoarthritis also will involve joints, but usually they come as with larger joints, doesn't it? But in case of rheumatoid, what happens is they usually come with a classical thing, that is the mornings. So now you have understood why they complain about morning stiffness, because this is a condition of synovium. What happens is whenever you sleep, don't move, the synovium is at rest. Now again the antibody come and damage your synovium. There will be lot of synovium at the rest. Once you start walking, because there is a lot of walking and there's all the other stuff, the synovium doesn't usually pay much attention to the antibody. But at rest, synovium is all into that antibodies, and hence whenever the patients of rheumatoid arthritis take rest, they get inflamed, they get swelling. So that is why over the night, 8 or 9 hours, they keep sleeping, right? In that particular time, what happens, this antibodies go and irritate the synovium and produce lot of synovium, and now this fluid gets accumulated into the joint, and whenever they get up early in the morning, they feel that their joints are swollen, especially the MC. Very, very important. The MC important, and now these joints get swollen, and over the period of time, over 1 or 2 hours, they keep on moving the joint, they get relieved of pain. So very classical morning stiffness. Polyarthralgia is seen in your rheumatoid, whereas in case of your osteoarthritis, usually they complain pain at the end of the day. Why? Because this is wear and tear. You keep on using it, it will keep on damaging it. That's it. So morning you are happy because you're not using all night. You feel very happy in the morning. You feel like, oh God, the pain has gone. Now over the period of time, I mean, you start using the joints. At the end of the day, by evening, they come with joint pain. So this is history taking, which is very, very important to ask the patients when is the pain actually bothering them, right? So much story I told you just to understand that there might be clinical scenarios asked in the exam. So now X-ray findings. So what you see the X-ray findings, there will be loss of joint space. Why there will be loss of joint space? Because the cartilage is damaged. Actually, what we see on the X-ray is the cartilage which is occupying, no, that is seen as the joint space. Now the cartilage is damaged, the cartilage is gone. Hence, as the cartilage, more and more cartilage is damaged, the bones come closer and closer. It is called as loss of joints. Then what you see, the most important thing, you see the subchondral cyst. Then what you see, this subchondral sclerosis. That means again the bone is getting irritated, will result in formation of more bones. So that is called as the subchondral. So there will be loss of joint space, subchondral cyst, and subchondral sclerosis, and you might also see the deformity on standing X. Ask for standing X-rays, and you see most commonly because the medial compartment is damaged. There is a varus. Right? These are the features of the OA. And now coming to RA. So RA, what is there? Again, you will see loss of joint space, but in this joint space, medial is more lateral. This loss of joint space, medial is equal to lateral. Means it is same on both the sides. And now, very, very important in rheumatoid, what you see? The pericar osteopenia. Why this is very, very important? Because around the joint, you see synovium, which is right. So that is why you see, yeah, and various deformities because of damage to tendons, right? So this is very, very important. You see various damage to tendons and knee erosion. Similarly, here also you can see the deformity on standing X-ray. So here, because it is both varus, valgus, depending upon which compartment is damaged more, and if it is both, you can see one important terminology which is called as the wind swept defect, right? That is, one is varus, another one is valgus. One is varus, one same side. So the wind is towards one side. That means one knee into varus, the other knee into valgus, which looks at both towards one angulation. So that is your wind swept deformity. The one more condition where you can see this is, yes, you can see this in, it's also the wind swept deformity, right? So this is about the osteoarthritis and your rheumatoid arthritis. So these are the important points you have to remember regarding them. And now most important thing is, so here this is a subchondral sclerosis which I was talking about. So first, whenever they give you an x-ray, you have to see for loss of joint space. So whenever this joint space is lost, so if you see here, this joint space is maintained, right? So there is some gap between the articulating surfaces. So here there is complete loss of this, and now you see there are cysts which are present here. So these are the subchondral cysts, and then you can see new bone which is formed. This is called as subchondral sclerosis. So all these are suggesting that this is a osteoarthritis of the hip, right? And what are the two important nodes or nodules which you see? The Bouchard's nodes and the Herbidens nodes. So how do you remember? The Bouchard's is BP and this is HD. So HD quality BP. So BP is Bouchard's is for proximal interpharyngeal joints, and HD, that is Herbidens, is for your distal interpharyngeal joints. Very, very important. Even though you understand the entire concept of your rheumatoid arthritis, what they usually ask is this, which is B, which is PIP, which is DIP. So again, we are depending upon the mnemonics, that is BP and HD. Right? So BP is Bouchard's proximal interpharyngeal joints, and next is Herbidens is distal interpharyngeal joints. Okay, is it clear? Everybody following? So next, coming to the deformities which in rheumatoid arthritis. So as I've told you, one is the windswept deformity. I've told you the second one is these two. You have to understand which is Boutonniere deformity and one is swan neck deformity. Why is this deformity actually occurring? So we already know that whenever there is rheumatoid arthritis, that is the synovium is getting inflamed. So whenever there is synovium is getting inflamed, again they will cause lot of tendon ruptures. They lot of damage to the other articular structures, plate, the tendon, or the small ligaments that are present around the joint. So whenever these are damaged, it will result in this deformities. For example, your Boutonniere's or the swan neck deformity. You see Boutonniere's and swan neck. These two you have to remember. One is Boutonniere's and swan neck. So what is Boutonniere's deformity? Boutonniere's deformity is flexion at PIP, extension at DIP, right? So what is this? Usually what I remember is, I remember swan is flexion at FG. So flexion at DIP is swan neck. Whenever there is a flexion at DIP, the contrary is extension at PIP, right? Exactly opposite is your Boutonniere. So please remember SFD, right? SFD, savings, what do? You put FD, right? So savings is FD, that is fixed deposit, right? You do a fixed deposit. So please remember that. So savings is fixed deposit, where the swan neck is your flexion at the distal interpharyngeal joint and extension the proximal interpharyngeal joint, right? And exactly opposite to that is your Boutonniere's deformity, that is flexion at the PIP and extension. So one more thing what you have to remember is all these deformities occurring in the hand. So we are dealing with the Boutonniere's, we are done, swan neck we are done, and what are the other things is ulnar deviation, and there will be a Z deformity also. So what is ulnar deviation? So this is the deviation of all the MCPs which will deviate towards the ulnar side. So this is the ulnar side, right? So everything deviates towards the ulnar side is called the ulnar deviation, and wrist deviates towards the radial side. So this is nothing but your Z deformity. So Z deformity is one towards one side, the other towards the other, like opposite side. So MCP is towards ulnar, wrist towards his radius. This is called as the Z deformity. So the four deformities, one is your span Boutonniere's, then the swan neck, then your ulnar deviation of MCP alone, or radial deviation of the wrist joint alone, or when it is occurring together, this is called as your Z deformity. Called as Z deformity. What is Z? Opposite. So MCP towards ulnar, wrist towards your radial. That is your Z diff. So these are all the deformities used. And what is the treatment of this rheumatoid arthritis? EMARD. So this is modifying anti-rheumatic drug. So you all know that the first one which takes place is your dexamethasone. There is a steroids. These are the steroids which we give, and after steroids, the position is by HCQ. So these are the two important things. Remember. So now again there are various types which do deal with the physiology of treating the rheumatoid. Now there are biological varieties also available. So steroids and NSAIDs are from the mainstay of the treatment, and now biological other disease modifying drugs such as so these are various other drugs which are now coming up for treatment of arthritis. Now how do you read the osteoarthritis? Of osteoarthritis. So here usually depending upon the staging. So staging you take if it is in grade 3 or grade 4, that is deformity, whereas deformity is in, go for total knee replacement. So this is the total knee replacement. Total knee replacement. That means you take up the, yeah, take off the femur, just the, so if this is the femur, the tibia, just remove the ends of it. So you distal femur and proximal. So you remove the ends and now you put this. What is this? This is an implant. Right? So this is the implant. So what is this implant? The difference between implant and instrument. So instrument, we use them. Implant, we place them. Right? So we are placing this implant. So this is called the femoral component. So you can observe, you can appreciate the shape of it. So this is called the tibial component, called the poly, like your meniscus in article. So just remember, whenever they put up an X-ray about this TKR, you have to be able to answer the femur component, the tibia component, and the poly, right? That is your total knee replacement. So this could be potential IBQs from the joints. Now coming to the most important one is your ankylosing spondylitis, right? So this is your ankylosing spondylitis. As you all know, ankylosing spondylitis is in girls and especially males of less than years usually. And now these are associated with HLA-B, right? So HLA-B27. And now what is the main thing? They are the involvement of the sacroiliac joints. They result in enthesis. This is the important word. Enthesis, the meaning. What is the meaning of enthesis? Attachment of the tendon to the bone. So there is an tendon, that side gets inflamed, which is as enthesis, right? Then there is most commonly there is of the joints, and you can see of skeleton. Then the skeleton, axial skeleton is spine, and it is also presenting with extra articular mass. So this will produce extra articular manifestations such as your uveitis, carditis, arthritis. That means it can involve various other important systems like your respiratory or retina or your cardiac system, right? So that is the mainly you have to remember about your ankylosing spondylitis. There are the certain one-liners they might. And now what are the image-based questions? This is your Faber. So the one test which can detect the SI joint pathology is your Faber. So flexion, abduction, and external rotation is your Faber, where they use this test for assessing the this SI joint. So whenever you do a Faber, that put the position of the leg in this, and you distract this sacroiliac joint, then patient wins with pain. That is your Faber, flexion, extension, and flexion, abduction, and external rotation. So what is the one more test? The one more test is your Schober's test. What is the Schober's test? Here what happens is there should be, because of the ankylosing spondylitis, whatever happens is there will be a restriction of the of spine. There will be a flexion. So this test is mainly to understand whether the spine is flexing or not. So first what you do, you identify a certain point. So this is called dimple of Venus that you all know. From there you approximately measure some 50 centimeters and mark it. And now you ask the patient bend. And now again you mark it. Difference is less than 5 centimeters. That means the lumbar spine restricted infection, which means it could be an ankylosing spondylitis. So called as the Schober's test. This is called as the Fibrous. These are the two important tests which you have to remember. And the first X-ray which you identify in case of your sacroiliac, identify in case of ankylosing is your sacroiliac joint, SI joint. So this SI joint, what you see what is called as the haziness, right? Haziness. Is you have to first comment on the SI joint. The involvement of SI joint is more in case of after SI joint, there is an involvement of your axial skeleton. So this is axial skeleton involvement. How does this get involved? So here what happens is there will be a lot of calcification, that is fusion. I know this fusion is by calcification. And there are the osteophytes, these are called as the syndesmophytes. So these are called the syndesmophytes. These syndesmophytes fuse entire spine, which is resulting in what is called. So this is called as the bamboo spine. So this is called as the bamboo spine, where the entire spine is united. This is called as the bamboo spine. And whenever there is a calcification of the posterior longitudinal ligament, this is called as the daggers, and the posterior longitudinal ligament calcified, which is seen as a dagger on the X-ray. So these two important X-rays, one is the dagger sign, the second one is bamboo spine, involvement of sacroiliac on testing the sacroiliac joint by your Faber and the Schober's test. So entire thing put up together is your ankylosing spondylitis. Are you there, everybody? So this is about the ankylosing spondylitis, very, very important. And usually they put the question with association with the extra-articular manifestation, like the patient having uveitis or pleuritis or carditis, and now there will be decrease in the chest compressions. So this all you can see the exam. That is the question, the clinic, right? It's about the ankylosing spondylitis, and now few other joint disorders which you have to remember. So one is the psoriasis. Psoriasis, what you have to remember. So mainly it is, so it is the pencil in cup, and psoriasis is a skin condition all know, and is treated with the steroids. And this psoriasis whenever present resulting in psoriatic arthritis are very destructive. There are very destructive. And what is the Casper's criteria? So Casper criteria is one thing which we use for diagnosis of psoriatic arthritis, right? And now this penicillin cup deformity is usually seen in the involvement of the distal interpharyngeal joints. Distal interpharyngeal joints are involved in case of psoriasis, and Casper criteria is used in case of psoriatic arthritis, and the X-ray finding is your pencil in cup deformity. And what is the one more thing which you have to remember? This causes arthritis lens. Arthritis mutilans means lot of damage. The entire joint is destroyed. This is arthritis mutilans. So what is this? This particular image is, this is hemophilia. Hemophilic arthritis. Arthropathy, where you see there is an increase or widened intercondylar knot. Widened intercondylar. So exactly starting the class, I've told you that we are stronger than what we think, right? So sometimes we may feel bored, or sometimes we may feel that we can't listen more to the class, but that is the time where you have to push up yourself to listen, right? So this is very, very important, all these IBQ. And if you just see them, or if you just keep listening to them, at least you can identify in the exam without, right? So this is the pencil in the cup, where you can see this pencil in the cup appearance. This is case of your psoriatic arthritis. Here you can see exactly the pencil in the cup. So this is the cup which you see, and the pencil, this is like the pencil, right? Ulta. So here it is like this, and now this, the joint is disrupted completely, so it looks like this. The pencil up appearance, and the Casper criteria you have to remember for psoriatic arthritis. Now this is your hemophilic arthropathy, where there is an increase or widened intercondylar notch. So usually the notch is like this, but in case of your hemophilic, it is. So this is the intercondylar notch which is widened. It is a condition which is called as hemophilia. And now what is this? This is very, very important, right? So this is a gout arthritis. This is gouty arthritis. Gouty arthritis, where there is an increase in the serum uric acid. So the increase in the serum uric acid, where now this uric acid gets crystallized. So it gets crystallized in the joint, and it causes erosion of the joint, which is called as a gouty arthritis, and usually seen in your first MTP. First MTP joint. It is most common the first MTP. And usually it is seen in case of your patient with alcohol. So male alcoholics, it is that is your gouty arthritis. And how the patient presents with, the patients you present with the patient usually present with the pain, the severe pain, tenderness there. You see the first MTP, and next it could be your knee joint also they produce it. And how do you diagnose it? You take the help of biochemistry, where you see for your, what is the serum uric acid presentation? It is presenting as birefringent crystals, right? Needle shaped crystals, birefringent crystals, which is a microscope, that electron microscope, birefringent needle shaped crystals, right? And what is CPPD? CPPD is nothing but it is pseudo gout. Here there is a calcium pyrophosphate deposits, and usually this is seen in case of your knee joint. So knee joint, we see this, which is called as the gout. So whenever they talk something about this calcium pyrophosphate deposition, and here this is the rhomboid shape. So this is the rhomboid shaped needles, right? And these are negatively birefringent, and these are positively birefringent. And this is all usually seen on the electron microscopy. Pseudo gout, and this is gout. So pseudo gout is mainly seen in knee, and it is rhomboid shaped crystals. Here it is a needle shaped crystals. These are negative birefringent. And what is this? Very important metabolic condition this. So this is nothing but your fluorosis. So you can see that is the yellowing of the teeth is seen, right? So this is the yellowing of the teeth. And now what you see on this X-ray. So this X-ray, you see there is a lot of sclerosis. So whenever you intake lot of fluoride, if you remember, the calcium hydroxyapatite is the main thing of the bone, right? So what is the composition of bone? It is calcium hydroxyapatite, right? So here what happens is the calcium fluoride is formed. So whenever the fluoride is increased in the body, they result in calcium fluoride. So this fluoride is very, very adamant for bone resorption. So very adamant for bone resorption. That means it will not allow the bone to resorb. Hence the bone appears like, the bone appears entirely white, which is called as this. A very, very important, this a metabolic condition where the bone appears hyperscleral, right? So it appears hyperscleral, right? So the fluoride, and this X-ray, it is seen in case of fluoride because of the calcium fluoride, where it is very not very friendly for the resorption. So it appears in high density, like it appears more white than the normal. So that is about the fluorosis. Okay, now coming to the metabolic condition. So we have started with the metabolic condition, that is fluorosis, and now we are dealing with two important conditions. So one is rickets, the second one is So you already know that the rickets is nothing but your defective mineralization. So what is defective mineralization? So wherever there is a decrease in the calcium, decrease in the phosphorus, but the bone is normal. So the collagen is normal, but the mineral content of it is decreased. So whenever there is a decrease in the mineral content like the calcium and phosphorus, now the bones become weak and now they deform. Don't break, they deform. So this deformity is seen in case of rickets, right? So this deformity is rickets. Hence, in rickets, you various there's varus deformity, the valgus deformity, or you see the wind swept deformity. So as you understood, the bone is formed by osteoid, right? What is osteoid? Osteoid is nothing but your main formation, that is your collagen, the collagen 1, and it is proteoglycans that you have to remember to understand metabolic disorder. So here what happens is the bone is formed by your osteoid, that is collagen, and your proteoglycans. Now this collagen and proteoglycans, once they are formed, they get by your calcium and phosphorus. So this calcium and phosphorus, they get mineralized, and this whenever there is a defect in the mineralization, it will result in rickets. That means what happens is the bones become very weak, that they tend to deform, right? So here on the x-ray, usually they take distal radius x-ray just to see three important things, which is called as the cupping, fraying, and splaying. So what are the three important things? The cupping, fraying, and splaying. The cupping is, so here what is actually happening? So there is a formation of the growth. The formation of the bone is in the growth plate, right? So usually this is seen in the growth plate, where the growth plate you have various. Yes, you have to remember this. There are 5 layers in the growth plate. So there is a zone of hypertrophy, reserve zone, then there is a cartilage. So that is how the bone is formed. So now what happens? The osteoid is normal, that means the bone is formed, but here the calcium is not deposited. Calcium is not deposited, hence now the bones appears lighting. See, everything is lysis in case of rickets, because calcium is the one which gives darkness. So if you see, there is a lysis here. So this complete absence of the calcium here results in case of cupping, and sometimes there is an extension or accumulation of the collagen, or there will be a slight accumulation of calcium over displaying, that is increase, and there is irregularity. This irregularity is called fray. So this is the cupping, that is cup like shape where there is absence of complete calcium, and now this extension is called splaying, and this irregularities here are called the fraying. So you see complete lysis in case of rickets. Whereas if you see scurvy, so coming back to scurvy, what happens in scurvy? Scurvy here, there is a is in vitamin C, right? So whenever there is a decrease in vitamin C, what is actually the vitamin C? Vitamin C is an important member in case of collagen cross-linking. So where is this collagen present? This collagen is nothing but your osteoid, right? Your osteoid, there is a collagen 1, type 1 is present. No, this collagen cross-linking gets disturbed. Now the bone becomes, here the bone becomes brittle because the collagen itself is deficient. And now if you see, because there is a more of calcium, curvy is full of calcium. So you can see the calcium is deposited around the epiphysis, which is called as ring epiphysis or Wimberger sign. Now the calcium is deposited around the growth plate, but there is no collagen as such, called as the dense zone of provisional calcification. And this extension of this is called the Pelkins spur. And now because there is a lot of a cartilage which is not present, you have this scorbutic zone, right? So there is some lysis which is present inside that, the other zones which represent, so that is your scorbutic zone. And because there is increased tendency of bleeding, there are subperiosteal hemorrhage. So what you have to think is, whenever there is a lot of calcium which is just opposite, a lot of lysis which is for rickets. So what is the Barlow's disease? This was asked. Barlow's disease. This is an important question. Barlow's disease is deficiency of both. What vitamin less, vitamin was question which asked recently. So now you're clear with rickets and scurvy. In rickets, there are other manifestations also depending upon the age group. So depending upon if it is an infant which present with rickets, so they have this ping pong bones over the cranium. This is called the cranium babies, right? And there is delayed closure of the fontanelles depending upon the age. And once they grow up, they feel this rhetic rose, right? So this rosary is all these areas where they become rounded and like the japamala, called the rhetic rose. And then they have this defect in the formation, that is again deformities that they present varus and this. So these are diaphragmatic Harrison sulcus. So all these are various manifestations of this which we see in children. And now scurvy, they present with bleeding gums, maybe bleeding gums which is present, and there are a lot of uh, wound healing problems. The wound doesn't heal well, so they present with a wound healing, right? So these are the important things about your rickets and scurvy. So how do you treat these rickets? You give vitamin D supplementation along with calcium. So here you give 6 lakh international units, right? Maintenance is 400 international, right? So this is how you treat the 6 lakh international units with maintenance by 400 international of vitamin D plus calcium supplemented in case of rickets, right? Now coming to spine. So this is again a very, very important question. So what is this? There is a deviation of the spine, right? The spine should be straight, which is not straight, where there's a lateral bending, which is seen called as called as scoliosis, right? And now this scoliosis is because it could be and post scoliosis, right? Or it could be pathological. So what is scoliosis? Scoliosis is nothing but a lateral or a sideward bending of the spine. See, the bending should be straight, but there is some problem in the straightness of the spine. There are two important things. One could be lateral and be forward. So lateral bending is scoliosis. Similarly, forward bending is kyphosis. So usually in the elderly people, you see they are bent like this, right? So they hold this stick and they are bent like this. That forward bending of the spine is called kyphosis. Few people, they have sideward bending of that is called as scoliosis. So what is the test which differentiate between postural scoliosis and pathological scoliosis? It is nothing but the Adams test. So what is this Adams test? Adams test is you want to differentiate between your postural scoliosis and your pathological scoliosis. So what happens is whenever you ask the patient to bend forward, if on bending forward the scoliosis is still present, then it is a pathological scoliosis. So bending is on bending also scoliosis. On bending the scoliosis is absent. A postural scoliosis. So why actually the postural scoliosis is happening? So this could be various reasons. One reason is because of the hip joint. So in hip joints, if the hip joints are not aligned or if there is some problem in the hip joint, now the spine tends to bend sideways. So this might result in postural scoliosis, right? So the Adams test is for postural, do differentiate posture and your pathology. Then what is research sign? This is your research sign. So what is research sign? So here you're taking the help of what? Iliac apophysis. Or taking the help of iliac apophysis. Why? To understand this skeletal, and this is mainly in case of your congenital optic. The most common form of scoliosis is very good. It is the most common is idiopathic, right? So in this condition, congenital or idiopathic, what happens? Young children, like maybe 5-10 years, children coming to scoliosis. Now, as they grow, because still potential, 5-10 years, they can grow up to 50, right? So up to 50, grow. And now because they have this growth potential, whether this scoliosis increases or whether it stabilizes, you will understand by the help of this skeletal mature. As the skeletal matures, the growth stops. right? The scoliosis, the angle of the scoliosis stops. So this is, you take the help of this iliac apophysis, where this 1, 2, 3, 4, and 5. So the fusion of the iliac apophysis. If the patient has come to you of some around 10 years, and now she is in grade 3 of iliac apophysis. So now still she has to complete 4 and 5. Then only it attains a skeletal maturity. Then only you can completely assess what is the angle. Otherwise, now at the 5 years, it could be some 10 degrees of scoliosis. By at the end of 15 years, it could be some 20 degrees of scoliosis. Now if you start correcting at 10 only, again the scoliosis, right? That is why we usually wait till the skeletal maturity. So how do you know whether the skeleton is matured or not? You take the help of this research sign, that is iliac apophysis, where you see the grade 1 to 5. So that is about your scoliosis. And now I was telling you about some angles. So this is an important question which was asked. So this is nothing but your Cobb's angle. So this is nothing but your Cobb's angle. So what is Cobb's angle? So here you will measure the angle of scoliosis mainly by drawing two important lines. These are called the apex vertebra. So one vertebra above, one vertebra below. Sorry, these are called the end vertebra. And this is the center one is called the apex vertebra. This is end vertebra. So you will draw a line over this superior plate and superior plate, and now you draw perpendiculars to this. So this and this actually are equal according to law of perpendicular lines. So this is called the scoliosis angle. So why you want to know about the scoliosis angle? Again, to tell them about the treatment. So here the treatment depends upon the angle, the Cobb's. So how the treatment depends? So if the angle is less than 20, you put the patient observation. So you will try to observe the patient. Angle is increasing or not. If it is 20 to 40 degrees, you put the patient fix. So there are various orthotics which are available, such as your braces. So there are various Milwaukee brace, the Boston brace. So you put on, and if it is then 40 degrees for depending on maturity. So that is how you have to treat the patient. So that is why you want to understand the angle of the scoliosis. So this is the Cobb's angle, the angle which is, this is Cobb's angle. Now what are these braces? So the first one is your Milwaukee. The first one is your Milwaukee brace. Very, very important. So if you see the Milwaukee brace, it is covering up to your occiput, right? It is even covering up to occiput. So this is the Milwaukee brace. And now what is this? This is your Boston brace. Boston brace, if you see, this is the dorsolumbar region. The DL region is covered. So this is like a box type. If you see the entire, it is like a box type. Remember, box type is Boston's. Milwaukee key brace. It is going up above. So that's the Milwaukee brace. And this is something which is called as Charlotte brace. Charlotte. So similarly like the Boston, but there is some extension of this. Like on one side there is an axilla. So this is the Charlotte brace. So these are the three important braces which you have to remember. So one is your Milwaukee brace, Boston brace, and your Charlotte brace. So that is about your scoliosis. And we have discussed the scoliosis. You have to first remember about the Adams test, right? And then whether this is this scoliosis is the degree, that is Cobb's angle. And then you will remember the research, and then most important the brace, right? So this is complete scoliosis. Then what about kyphosis? Kyphosis, as we told, this is the forward bending, and usually kyphosis we osteoporosis, the Sugarman, and even in case of tumor. These are the conditions where you see kyphosis. This and there will be forward bending of the spine. Is your kyphosis, right? Now, these are some of the important IBQs where you have to understand which type of brace it is. As we have already told you that orthotics are mainly to help. They supplement and they put the limb in the functional position, right? So this is what is this? So this is called the halo west brace. So this is very easy. Halo west braces. You can see there is one halo, like the emoji, halo emoji we have, right? So similarly, you have this halo round. So that is halo west. As you see, it is mainly useful for your cervical pain or any problem in the cervical spine. So this is stabilized and the spine is maintained in extension. So that is your halo vest. Then what is this? This is called the four post collar. Similarly, there are four posts on two on the anterior side, two on the posterior side. This is called the four post collar again for your cervical spine. So just remember these are the cervical spine braces. Usually the names of these braces would be more than enough. Just identify them, that is more than enough for you. So this is the halo west brace. Just remember the halo I told you, and four post. They have four posts like this. The four post. And what is this? Called the somi brace. So this is sterno, occipit at the backside, and the mandible, right? So this is somi brace where they give orthotic, that they give support to sternum and connected by the occiput, that is on the back, and then on the mandible. Called the somi brace. Very very important asked. So remember this is the somi brace, right? And now, this is very important again because this is regularly used in the ward. So this is called the Taylor's brace. What is Taylor's brace? Taylor's brace is used for T for tuberculosis. So this is dorsolumbar corset also. That means it gives support to dorsal and the lumbar region. This dorsolumbar corset called the Taylor's brace. As you remember, this is mainly for the tuberculosis. Case of tuberculosis. Okay, and now name some of them. What is this? This is nothing but your soft collar, mainly in case of cervical accidents or cervical spondylosis we use. But in case of trauma, which is very acute trauma, what we use is the hard collar. And there is one more collar which is called as the Philadelphia collar. It has a tracheostomy hole. So sometimes we need to put this patient's cervical injuries patient, we need to put them into the collar. So whenever there is an acute injury, we try to put them in hard collar. Sometimes they have this breathing difficulty and we require tracheostomy. That time we can't open the collar, right? So there is a hole which is made in front of the neck, which is called as collar. That is for the tracheostomy to be right. And now whenever you want to immobilize patients with cervical spine injuries, you always use them with the hard collar. And if the patient is suffering with some blunt injuries, spine or scoliosis, suggest a soft collar. So here in the image, this is the soft collar which they are showing. Now, what is this? Yes, this is your Thomas splint. So what is Thomas splint? So Thomas splint was originally it was discovered during, or it has actually invented during World War II for people suffering from tuberculosis, making them for immobilization. And now for what they use the Thomas splint? They use for the femur fractures. They use for femur fractures, shaft fracture, right? Yeah, Thomas splint is now used for femur shaft fractures, especially for the immobilization. Immobilization, like if a patient has come with femur shaft fractures, and now this patient is also having a head injury. Now you have to shift this patient to the CT because brain is more important than the right. So now what you do, you apply a Thomas splint to this patient and you immobilize this patient in CT room, right? So that is how this Thomas splint is used, right? So this is for shifting the patient from one ward to other, like that this Thomas splint is used. So what you have to remember about the Thomas splint, the first thing, there is a ring. and there are two bars, outer bar and inner, right? So outer bar, if you see, there is GT, because on the lateral side, the outer side, if you palpate over the proximal femur, you have to accommodate the GT. That is why on the lateral, so this is the ring. On the lateral side, there is something like this, and to accommodate, and then you have your bar. So this is for your GT. And now the inner side, it is making an angle of 120 degrees. And now these two bars are connected by a W shape structure. So this is your muscle. And now what you do, you put the limb inside it like this. And now you put the bandage or crepe bandage. So this is mobilize the limb. So this is the Thomas, right? Important things, outer bar, the inner bar is making of 120 degrees. It is a ring. Why I'm actually telling you all this? Because the Thomas splint will not be available like this. You have to prepare the Thomas splint. You have to take a ring. There are various rings which are available. So you have to measure the circumference of the thigh and then take the appropriate ring. And then you will take the bars and then you do it by yourself. You connect it by yourself. That is why you have to understand what are the important parts of the Thomas splint. And similarly, what is this? A very important thing which is called as Bowler's Brown splint. So it is called as the BB splint, the Bowler's Brown. So what is this for? So this is again for traction. So there are two types of traction. Here we come to understand. One is skeletal traction. Second one is your skin traction. So for the skeletal traction, whenever you put tibia pin, upper tibial pin, that is your Stevens pin or your Dunham pin, you put the pin, right? And then what you do, you put the limb onto this. So this is your limb position over this, right? So now there is a pin which is putting in the tibia, the upper tibial pin, and now you put a pulley over it, right? Now you try to hang it. So there is a pulley like this. There is a pulley and now you try to hang it. So based upon that, you have to use this splint. So BB splint is mainly used for, again, it is used for femur fracture. So femur fractures, you put upper tibial pin and now you put this on this BB splint. And sometimes this pin, if you see this BB splint, this has three things, right? So this is mainly for your femur. So this is in line with the, right? So this, and this is for your foot drop. So this upper one is foot drop, the lower one is for your femur, and this is directly for your tibia. Right, so based upon your fracture, you use this BB splint. So just identify this BB splint and where it is used as tibial traction. So here you put the weight. So for this pulley, put the weight. So this is the weight you put, right? So that is how you give this skeletal traction. So usually nowadays we are not giving so much of skeletal traction because our OTs are available, doctors are available. So we are immediately taking the patients for surgery instead of putting, because in the setup they used to take some 3 to 4 days for each patient to get time. They will use this BB spray. And now also if there is any complication, such as if the patient is having head injury, the patient operated immediately or involved in case of polytrauma, this BB splints, right? Now coming to trauma. So very, very important, very, very easy. Now we'll finish it in maybe 15 minutes. So now what is this? This is a, yes, you can see the bone is abnormal, right? But there is a fracture. So whenever there is a bone abnormal when presenting with the fracture, called as the pathological fracture. Then what is this? Contrary to that, here the bone appears to be normal, but there is a fracture. But what would be the reason of this fracture? So this reason of the fracture will be multiple attempts making small atoms, like multiple forces which are acting on that particular. This is called as the stress fracture. This is called as the stress fracture. This is called as the pathological fracture, right? So why is this so important for us? So pathological fracture, the forces. So how actually the fracture happen? The fracture usually happens because of the forces generated, right? The forces generated are too hard on the normal bone where it breaks, right? Or the fracture happens if the bone is abnormal, the force will be minimum. So this minimum force, whenever there is creating failure of the bone, is called as a pathological fracture. You remember? So whenever you are taking a history of the patient, you have to inquire about the forces. You have to ask them, why did fracture happen to you? I mean, whether it was a forces like the road traffic accident or just a small force. If they tell you it is a small force, like the patient was walking and slipped and hit proximal, this could not be the reason for proximal humerus because this is a strong bone. The proximal humerus is a strong bone, and that too in case of a 30 years old. If he is presenting with proximal humerus fracture, then you have to suspect a pathological issue because the bone is abnormal. Even with small forces, it is resulting in fracture. Here in stress fracture, what is happening is repetitive activity. Repetitive activity where there is a small forces acting together will create the fracture. For example, March fracture. So what is this March fracture? So you see the soldiers, whenever they're recruited in their early days, they are continuously trained for march. And as they hit the foot onto the floor, every time forces are acting in the same place. That is your second metatarsal area resulting in fracture, which is called as the stress fracture. So here there is a stress. The bone is under stress resulting in fracture. This is called as a stress fracture. So this is second metatarsal fracture. Here you can see. So sometimes the patient only present with callus, that is swelling. So now the patient comes to you and he says there is a swelling. Why I don't find this? There he will ask, I have not fallen anywhere. There is no force only. And how does a fracture can occur at that particular? Then you have to explain. And this is because of the repetitive stress they have given by marching or dancing or whatever thing, but the repetitive stress. There's been fracture which is tibia most common for stress fracture. Yes, tibia is the most common site for stress fracture in case of your osteoarthritis. So I have told you in osteoarthritis the medial compartment is damaged and now the patient is neglecting. Even if it is a varus deformity, the patient neglecting doesn't come to end, that might result in tibia fracture, right? There is nothing the most common site for stress fracture. The stress fractures are mainly depending upon their actions. Like for example, in case of your soldiers, I've told you the second metatarsal fracture. And pathological fractures, mainly in case of your osteoporosis, also it is a pathological fracture, right? In case of your hip fractures, distal radial fractures, so you have to evaluate them for osteoporosis. From also they result in fractures. So now what is this? So here what you have to understand is the fracture has happened, right? And now it heals. Heals by 5 stages. If it is not being called as an, right, on you. If the fracture is healing but not aligned, so always remember in ortho, it is the alignment, the length, the rotation, alignment, right? The length, the rotation, and alignment has to be correct so that there will be use of that particular bone. For example, if it is not aligned properly, it will result in damage to the biomechanics of it, right? So that is why whenever it is not aligned, we are not happy with that union, and this we called it as malunion. So it is not aligned, but union has occurred, right? Here this is non-union. Non-union का मतलब क्या है? Here there is no fracture which is uniting. So for example, if this is, so now there is a fracture, you can see. Now this fracture, if you see, the ends are tapered like this and there is no bone in between. Your non-union. There is no union only. And now coming to this, there is a union. Happily bones are uniting, but are they aligned? So the axis, you see, there is a lot of difference between the axis. The biomechanics get disturbed. So here, if you see, This is the proximal part, and this is the distal part, right? So proximal, draw long axis of the bone, distal, you draw long axis, not aligned properly. So this is your malunion. Very, very important, and malunion. These two are important complications of the fracture. So what are the sites where you see this non-union and malunion, and why actually they appear? So what you have to remember in case of non-union is vascular. So why actually the bone unites? The bone unites because there is a blood supply. So there is a blood supply, there is a nutrients. So hence the bone unites. So there are certain areas such as talus. Then there is a head of femur, and then there is scaphoid. So here what happens here, these three areas, you have to be careful about the vascularity. So the peculiar blood supply is there in these areas, which will result in non-union of these fractures. For example, talus, neck fracture, scaphoid waist fracture, and head of the femur or the neck fracture, that is IC, intracapsular fracture. So these three areas where because of the abnormal blood supply, these particular areas will to non-union. And what is malunion? Malunion is of distal radius fracture, where you see malunion, that is a dinner fork deformity, right? And then you see the gunstock deformity in case of supracondylar fracture of humerus. In case of supracondylar fracture of humerus, what happens? The union occurs, but it is malunited. Hence, it is deformity. So you will see various deformity like the gunstock deformity, Gardner's deformity, Barton's fracture, right? And then in case of supracondylar and in case of IT fracture, that is intertrochanteric, that is non-union. Intertrochanteric is, so this is about the important things about union and malunion, right? Hope you all understood. Now going to this. So what is this? This shoulder dislocation. So there are three types of shoulder dislocation. So one is anterior shoulder dislocation, posterior dislocation, and inferior. What is important thing you have to remember? There is a damage to the axillary nerve in case of the shoulder dislocation, especially in anterior and posterior. The most common is anterior. And posterior, you know, there is a light bulb, right? So this is light bulb. And inferior, you see there is an hyperabduction. So this is the hyperabduction. So whenever there is a hyperabduction, there is an inferior dislocation. And in case of your anterior dislocation, what are the tests which you have to remember? Yes, that is the gas Callaway's, right? Hamilton ruler test. So Dugas test, touch the opposite shoulder. When you're able to touch the opposite shoulders, that means your shoulders are intact. The shoulder dislocations are intact. And light bulb sign, and this what you have to remember, it is usually seen in case of epileptics and shock, electric shocks or epileptic patients. And inferior is hyperabduction. So completely the attitude of the limb is also in hyperabduction position. So that are the important things. The most common dislocation is anterior dislocation. Nerve damaged is axillary nerve in case of shoulder dislocation. What are the complications of habitual shoulder dislocation? So two things. One is Bankard's, and the second one is, so what is Bankard's? Bankard's is Brum defect. Second one is Hill-Sachs. So Hill-Sachs is humeral head defect. Just remember. So whenever they ask you H for H, remember Hill-Sachs, humerus defect. This humerus on the posterior, anterior side, right? So the labrum gets torn. That is your Bankard's, right? What is Hill-Sachs? Hill-Sachs is humeral defect, right? So these are the complications of habitual dislocations of humerus. Now, what is this? Again important, that is supracondylar fracture of humerus. So in case of supracondylar fracture of humerus, so we know that the most important thing which you have to remember is damage to the anterior interosseous nerve. So there will be damage to the anterior interosseous nerve, mainly followed by median nerve, followed by radial and the ulnar nerve. What is another important thing which you have to remember? That is damage to the brachial artery can also happen, which results in Workman's ischemic or the splint, which is Workman's splint, which was asked and splint because of the brachial artery fracture. So fractures have certain complications. So first one, what you have to understand, and then they can be nerves and the vessels. Most importantly, in patients you have for the axial nerve, in case of super, what you examine is your brachial pulsation, brachial artery, because there will be damage to the brachial artery as this artery just so whenever this artery is going like this, and this fracture might hit or break the artery or disrupt the artery, hence you have the pulsation immediately. Otherwise, they can also damage the nerves. So what are the nerves damaged? The first one is the iron. How do you remember? Amru, right? So this is anterior interosseous nerve more, next median, next radial, next ulnar, depending upon your displacement. And now what is important? Now this supracondylar fracture, what is the meaning of supracondylar? That means it's above the condyle. That is, it is occurring somewhere in the metaphysis. So this Salter Harris 1 or 2. Usually it is not in the group, right? It is above the condyle, right? So this is right. And now whenever this supracondylar is not treated properly, this will result in uveitis. What is this? Uveitis varus. So this deformity is called as the gun stock uveitis varus or gun stock deformity. So this is the supracondylar fracture that is above the condyles in the metaphysis, right? It is in the metaphysis. And now, whenever there is a lateral condylar fracture, what I mean by lateral condylar fracture, that means the joint which is called as the intra-articular fracture, right? So this intra-articular fracture will result in what is called as cubitus valgus deformity, because the lateral end will not grow. Okay, this will result in cubitus valgus deformity, and here you have to remember there is tardy ulnar nerve, right? This is also very important. Tardy ulnar palsy, tardy means it's slow. So slow ulnar palsy, that means the patient who had the fracture of lateral condyle will present with the claw hand. So ulnar palsy, claw hand, right? So whenever a patient of age may some 50 years and he had past history of a lateral condyle presenting with claw hand, what is the reason? It is the tardy ulnar palsy, because in the lateral condyle there is an extension in the articular region, and now on the because of the lateral condyle is being disturbed. Now the medial condyle gets stretched. Medials. So this medial side, the ulnar nerve gets stretched, resulting in this palsy. That is tardy ulnar palsy. And what is this? Coming to the forearm, very important, two important. So one is Montegia, second one is Gillies. How do you remember? So Montegia is M, right? M means medial, that is ulnar fracture, right? Gillies is, yes, is ulnar, one is radial. Now Montegia, what you have to remember is proximal radial head dislocation. This is distal radio ulnar joint. How do you remember? Murg. M-U-R, right? So medial is Yes is Galax. And Murg famous in the Punjabi dub, right? So Murg for P, RG for D, right? So Murg and PD, Murg Punjabi Daba, you remember Murg is medial side ulnar fracture, that is Montegia is ulnar fracture. Now you can identify, so this is ulnar fracture with the proximal radial head dislocation. Before that, understand this is a fracture dislocation. Very, very important, fractures of necessity. So whenever there is a fractures immediately, so these are fractures of necessity, right? So here what happens is there is a fracture of the ulna with the proximal radio ulnar joint disruption, the head dislocation. Here there is a fracture of the radius, and now DRUJ disruption. It's about Montilla and Gilly. So very, very important. They ask the exam. And now what is this? Various, just you can write the names. So the first one is the distal radius fracture, usually seen in case of dorsal displacement, called as an extra articular, right? So it does not involve the joint. Extra articular with dorsal displacement, name given is Colles fracture, right? So you put the Colles cast in palmar flexion, ulnar deep. That is important. And whenever you don't treat it properly, it will result in what is called as union, and this is the inner fork T, fork deformity. Similarly, if this is going into ventral displacement, right? Ventral displacement, it's called as Smith chart. So this malunion is called as garden spade. Understood? So this is the dinner fork deformity and garden spade deformity. So we have to remember both of these are extra articular. One is dorsal displacement, the other one is ventral or palmar displacement. Dorsal is this side above and ventral is this side below, right? So this is dorsal displacement. Fracture happens and the distal fragment will come up. So that is dorsal. And fracture happens, the distal fragment will go down. That is palmar displacement, downward displacement. So both of them result in no malunions. The one is called the dinner fork deformity. The second is called the garden spade deformity. Very, very important. And now coming to most important thing again. So in the carpal bones, we have one important thing, that is scaphoid fracture. So now the patient comes with pain in the wrist joint, and now you have to examine for the anatomical snuff box. To examine for the anatomical snuff box, and here if there is tenderness, then you for scaphoid scaphoid fracture. Whenever there is a tenderness, you go for fractures. You have to ask for the X-ray. So then you go for wrist AP X-ray or PA X-ray, and then you go for oblique X-ray. So this is a deviation or the oblique X-ray. On the oblique X-ray, you will scaphoid. Usually scaphoid missed. So this is the anatomical snuff box. Asked sent FMGE, I mean last exam FMGE. So this is the anatomical snuff box, especially for your scaphoid. And scaphoid, as we have already discussed, it goes as a tendency on union, and this is identified on the MRI. And you can see the bone has been necrosed. So this is the non-union, especially in the neck, because the blood supply is from distal to proximal like this. So here, whenever there is a damage fracture, the distal to proximal blood supply is restricted, and now this part goes across. So how do you treat the scaphoid fracture? Not the non-union. I'm talking about only the scaphoid fracture. How do you treat them? You cast this called as glass holding position. Called as glass holding position. The scaphoid cast. How do you identify? The thumb is included into the cast. Colles cast, the thumb is not included. How you identify the cast? So this is the glass holding position where the thumb is included, and now in the Colles the thumb is left. And now this, so in the thumb or the first MCP, we have two important fractures. So one is called the Rolando. Second one is called the Bennett's fracture. So how do I identify Bennett's and Rolando? And please remember, both of them are intra-articular fractures. So both of them are intra-articular fractures, but Bennett's is bi. B for B. B means 2. So whenever you see a fracture fragment with 2 pieces, so here you see there's a fracture with pieces, one piece, one piece. And the second one is 3 pieces, right? 1, 2, 3. So B is for Bennett. So which one is Bennett's here? This is Bennett's and this is Roland. Rolando is 3. Right? Bennett's is right. So what is one more thing which you have to remember? The Bennett's requires reduction because of this particular muscle, that is your abductor pollicis longus, right? So your APL, abductor pollicis longus. So now this get attached to this larger fragment, not the smaller one, larger fragment, and pulls it down like this. I have given in the image also. Because of the pull of that muscle, because of the pull of the muscle, there will be disruption in the union of the fracture. Hence, you have to put them under a proper reduction, right? So pinning that we put KYS and Rolando is 3. Bennett's is by Rolando is 3. Then what is this? What is this? Neck of fifth metacarpal. Neck of fifth metacarpal is, yes, it is boxer's fracture. Boxer's fracture is you make a fist and you hit it into the wall or hit it else. It is the boxer's fracture. So fifth metacarpal is boxer's. And what is this? The small thing. This is nothing but your ulnar collateral ligament. Ulnar collateral ligament is gamekeeper's. Just remember, gamekeeper's ulnar collateral ligament. Just remember the name. Gamekeeper's thumb is ulnar collateral, right? And now coming to the lower limb. So what is this? This is the pelvic binder. This was asked in the NEET PD. So here the patient has come with polytrauma, and you're suspecting a pelvic fracture. And what is the first step you for stabilizing this patient? So whenever there is a pelvic fracture, as the pelvic is a bone which is protecting various organs, and especially it is rich in the important blood supply, right, such as your iliac arteries. So whenever there is a pelvic fracture, you have to first stabilize the circulatory system because of the drop in so for that, what you do, we put a pelvic there. The first step what you have to do as a patient pelvic fracture, suspected pelvic fracture, put this pelvic binder. So these are the pelvic binders. So this is actually the binder. If the binders are not available, you can take a bed sheet and put it around the pelvis at the level of great trochanter. Identify the both ends great entire bed sheet tightly so that whatever is opened like this, now the pelvis becomes. So the first immediate step you have to do is stabilize the circulatory system, that is follow A, B, C, D. And when you see the pelvis is involved, you put a pelvic binder as the first step. Okay, that is the answer. And now what is this? So these are the dislocations, very, very important. Okay, so this dislocation, this is the posterior dislocation of. So in case of posterior dislocation of hip, what is the attitude? The attitude flexion, adduction, and internal rotation. So very, very important, the attitude. And if you see the lesser trochanter here, so here you see there is a lesser trochanter. So here you can't see the lesser trochanter. So the absence of LT on the X-ray because of the internal rotation. So this gives an idea that is it is clear dislocation, and immediately you have to go for. And the nerve which is damaged here is the sciatic, right? So this is the very important thing. So the dislocation, identify it is on okay. So LT is not present, hence and on the clinical you see there is a flexion, adduction, and internal. Here reduction is here. Most common damage is to the nerve, that is sciatic nerve. Okay, then what is this? There are two important hip fractures. So one is the intercapsular fractures, second one is intertrochanteric fracture. Intercapsular fractures will go into non-union as and IT fractures will malunion. Non-union because the capsule is present, the synovium is present, which will not allow occur. And malunion because there is a lot of callus formation, but it should be aligned properly by the treatment of this is hemiarthroplasty. So recently, there are two questions which are asked on hemiarthroplasty. So a patient of 60 years old presents with IC fracture. What you do, as you already know, the head is at risk of non-union. You go for replacing the head, which is called as hemiarthroplasty. And if it is an IT fracture, you go for proximal femoral nailing, PFN, because the head is not at risk, because the blood supply is not disturbed, it is only disturbed in the bone. So now you go for of this fracture. So this is proximal nailing. But in case of IC fracture, where the neck is disturbed, so whenever there is a fracture neck IC, so there is a blood supply which is there. If you remember from your anatomy, the blood supply of the head is like this, right? So this fracture breaks the blood supply. Hence, this particular head AVN. Hence, what you do, the treatment. If the patient is more than 6 years, you go for hemiarthroplasty. Patient is less than 50 years, you can go. So the treatment of IC depends upon the age of the patient, right? That is about it. And now what is this? Femur fracture. That's very, very important because this might result in fat embolism syndrome. Fat embolism syndrome. One important complication of fracture is fat embolism syndrome. So this is the fracture. How do you treat it? Usually the medullary interlocking, because after fracture requires callus. So in case of nail, there is a lot of callus formation. Hence, we treat with intermedullary interlocking rather than locking screws. And if this particular fracture has occurred to in less than 2 years, what you do? You put a gallows, right? It is 4 years. Then you treat with hip up. It is 4 years, tense, right? So this is how you treat the patients. So one patient femur fracture, if age of more than 18 years or more than 18 years, usually they present with fractures. If the patient is 4 to 8 years, we go with tense. At 8, we have to decide whether we are. So this is how the femur fracture. So first femur fracture, intermedullary, the treatment is mainly the nailing because the callus has, because it is a bone, you require more of calcium. So that is the intermedullary interlocking nail. And then if the infant is less than 2 years, if it is a patient of less than 2 years, you go for gallows traction. If it is 2 to 4 years, you go for hips. More than 4 up to 8, you go for titanium elastic tense nail. The tense, right? So the type of nails which you can insert the bone, and now these grow along with the bone as the patient, the nails elastic, right? That means they accommodate the growth. That means the nail they can't increase, but it accommodates the growth of the, right. That is tense. That is about. Now coming to the patella. So in case of patella, what is this image about? So this is the cylindrical cast. Cylindrical cast for patella fracture, and this is the skyline view. So this on identifying the patella fracture, especially the skyline view is used when to identify the patellofemoral joint. So usually what we do is we take the AP and the lateral views, right? So we take the AP view here, and this is the lateral view. Lateral view, it is not here, but usually in the AP and the lateral view, we don't find the patellofemoral joint. To identify the patellofemoral joint, you go for this skyline view. That is the important thing. So to identify this, you go for the skyline view. And next, what is this? This is recently asked, called the biparitate patellae. It was asked in the previous NEET, I think. Patellae. So they've given the X-ray. Student got confused between the patella fracture and biparitate patella. So biparated patella is a condition where you see a small fragment of patella. That means two patellae are seen. Usually this is a bilateral condition, right? So this is usually a bilateral condition. And what you see, the fracture ends are unequal. So here if you see the fracture, you can see the ends. So the fracture ends you clearly. So irregularities, right? Now you see biparated patella, what happens is it's like this. So there is no fracture end like this. As in fracture, it is so that you have to identify it on the X-ray. So that is the patella. You have to use electrical cast and then you treat it with TW, that is tension band wiring. TW, the treatment patella fracture is tension band wiring. That is what you have to understand about it. And these are the various tests. Now coming to the various tests which are used. So first let us start with the ACL, anterior cruciate ligament. So this is the anterior drawers test, right? And then this is for your meniscus, right? Whenever there is a rotation like this is the meniscus, that is your McMurray's test. And standing on the one line, this is called your Tesselli's test. And this is your Epley's grinding test, right? So what are all these tests for? This is all for your meniscus. So meniscus has three. One is McMurray's, Apley's, and Tesselli's. These are the three. And ACL, there is an anterior draws test. Then there is a pivot shift test, right? So anterior draws test and pivot shift test is for ACL. Meniscus, we have three: McMurray's test, Tesselli's test, and Apley's grinding test. And what is this test? This is called the varus stress or the valgus stress. So this is mainly given for your collateral ligaments. What are the collateral ligaments? MCL and LCL. So MCL and LCL, you do a varus stress or a valgus stress. And hi Nikhil. And for meniscus, we have, what are the tests? We have the McMurray's test, the Tesselli's test, and the Apley's grinding test. And for the ACL, we have the anterior draws test and the pivot shift. And now what is this? This you have to remember. This is your Thomas test. So what is this Thomas test? Thomas test is mainly used for identifying flexion deformity. This is also asked in INICT. That is the fixed flexion fixed flexion deformity of the hip joint. Just remember flexion deformity, Thomas test. That's it. And now this is all about your lower limb. So ACL, anterior drawers, meniscus, McMurray's or the Testes, and Apley's. Valgus and varus is your collateral ligaments, right? And your fixed flexion deformity is by your Thomas test. And now coming to the upper limb, that is your rotator cuff. So your rotator cuff, there are four muscles, right? The sit muscles, supraspinatus, the infraspinatus, the subscapular. That's all you know. And what you have to remember is for supraspinatus, empty can test. And these two, they are external rotators, right? So just you have to see lag, external lag, that's it. And for subscapularis, we have two. One is belly press and second one is Gerber's lift off test. So two important tests. So this is your empty can. Empty can. So this is your thumbs up empty can. And try to abduct it as shown in the image. So you're going to put it like this and then you try to go in there. Then you're trying to abduct it under resistance. That is the empty can. And then lift off test. So you're going to do internal rotation and you're trying to lift the, so you're trying to lift hand from the back. So this is your lift off test. You lift the, then belly press. This is very easy. You press the belly. So pressing the belly is again internal rotation, right? So testing for the internal rotation is subscapular. Testing for external rotation is for your posterior and the infraspinal empty can test. Now, what is this? So I have told you the fixed flexion is Thomas test. And then what is this? This Thompson's test. Thompson test is for your tendo. Thompson test is for your tendo. So whenever there is a tear or rupture in the tendon, you try to squeeze your calf muscle. Squeezing the calf muscle, plantar flexion of the foot, right? So this plantar flexion of the foot on squeezing is absent. Then there is a rupture of the tendo-Achilles. If you remember, the tendo-Achilles is from the soleus and the gastrocnemius together form a huge tendon on the back of your leg, and they get inserted into the calcaneal tuberosa. So on crushing or on uh, So on squeezing the calf muscles, if there is a plantar flexion, then there is a tendo-Achilles which is attacked. And if this is not causing any put on that squeezing of your calf muscle, then it is Thompson's test. For tendo-Achilles, it is Thompson, and FFD, it is Thomas. And what is this? This straight leg raising test. This straight leg raising test. This is mainly used for both the things. One is active, second one is passive. If it is active, it is for the hip joint. So you have to test it for the hip joint. The patient itself has to lift it up like that with the knee in extension. And passive, it is made for prolapse intervertebral disc. So prolapse intervertebral disc, whenever you lift by the surgeon or the doctor is lifting the leg, they cause a stretching of the sciatic nerve and patient with the pain. That is your passive SLRT, that is straight leg raising test. Okay. And now coming to this is the MRI of your ACL and the PCL. The normal ACL, this is the normal PCL. Absence of the ACL and PCL on the MRI tells you that it is a tear in the ligament. That is ACL tear, MCL tear, you treat arthroscope. And what is this? So these are the ankle fractures. So ankle fractures, what you have to remember, there are bimalleolar, means two malleoli, medial malleolus, lateral malleolus, called as the Pott's fracture. And when it is trimalleolar, that is the posterior malleolus, it is called as Cotton's fracture. Pott's fracture, Cotton's fracture. Bimalleolar is Pott's, trimalleolar is Cotton's, right? And this classification name is also important. That is called the Lange-Hassan's for your ankle fracture. So this is the Lange-Hassan's classification, right? And now coming finally to the these are the three important angles they might ask you. This first one is called the carrying angle. So you know that the forearm and the arm are not in a straight line, but the long axis of the arm and the forearm makes an angle which is the carrying angle, which is more in. And if this carrying angle is increased or decreased, this results in varus. That is this varus or vitis. What is normally we are present with? We are present with valgus. Normally we are present with valgus. And now if this this is rotated inside, this is cubitus, varus as we told in the gunstock deformity, right? And now that is carrying. Then what is this? The called as the kite's angle. So what is kite's angle? The angle between talus and the calcaneum. Talus and the calcaneum is called the kite's angle, and usually they make an angle of some degree. But when they are straight, that is 0 degrees, that is parallel to each other, indicative of CTEV. This, right? Parallelism of talus and calcaneum is Anshu, it is already good night. You're telling. And now these are two important angles in the calcaneum. So there are two important angles. One is called the Gisane, angle of Gisane, and angle of Bowler. So this is Bowler's angle and this is Gisane's angle. So what is Bowler's angle? So first you have to identify the facets. So this anterior facet and this posterior facet. This So one angle, one line you draw along this connecting the anterior and the posterior fossa. What I'm talking. So now what you do, you calculate the post anterior height and posterior height, and you connect one line. The second line you highest point of calcaneal tuberosity, and then you draw a lines like this. So this is your Bowler's angle. And then we have the Gisens again along the strut. So this is, I told you, no, this anterior and the posterior. So along the struts you draw the lines. This is your Gisens angles. How do you remember? Gisen, G is that is gains in case of calculus. Fracture, Bowler's low. That means decreases in case of fracture calc. So whenever you're treating the fracture calcaneum, you have to record this angle. That is your Bowler's angles and the Gisens angle. So in case of calcaneum fracture, the Gisens angle increases. The Bowler's angle decreases. Right? So the decrease in the Bowler's angle and increase in the Gisens angle will tell you about your calcaneum fractures and their fixation. Right? And then what is this? This is your talus fracture, or it is called as aviator's fracture. And this talus has also the potential of going into non-union, as we have discussed. So this talus, and the question was asked is Hawkins classification. So Hawkins classification in case of talus fracture. And what is this? The fifth metatarsal base. This is your Jones fracture. Metatarsal base is your Jones fracture, right? Just remember the names. The tarsal is called aviator's fractures and it is potential for non-union. And fifth metatarsal base is called the Jones fracture, right? And what is this? This is the pediatric fractures, right? So these are the pediatric fractures. Just to remember the names, the buckling is called the torus fracture. So usually this is given the name as the pillars. So whenever there is pillars like this, there are some there's some bulge like this, right? So this name is called the buckling or the torus fracture. And this is your green stick fracture. One cortex is breaking. This is usually seen in pediatric features because if you take a stick which is full of water and now try to break it, it will not break as a dry stick. So there will be some resistance for its breaking, right? So that is why it is called as a green stick fracture. And now this is torus. There's just a buckling of the cortex is called torus. And now this is called toddler's fracture or the runner's fracture. That means there is a small fracture in the tibia. Sorry, not the runner's fracture. It is just the toddler's fracture. Toddler's fracture, it is seen mostly in the tibia. It is an undisplaced fracture. Usually because of the slip and fall, they result with this type of fracture. And what is this? Called as the night isolated fracture of ulna is called as the nightstick fracture. That is ulna fracture, right? That is about your fractures. And what is one thing we are left with the pediatric orthopedics? So this is called the Salter-Harris classification. Very, very easy. I'll tell you in just seconds, right? So just remember Salter-Harris as the Salter only. S-A-L-E and R. So E and R is the fifth one and S is the first. So type 1, type 2, type 3 and type 4. There are 5 types in case of Salter-Harris classification. For this you have to remember the growth plate. So growth plate, whenever there is zone of hypertrophy which is supposed to be the weakest area in the growth cartilage and there is a straight fracture to the growth plate, right? So there is a straight fracture to the growth plate, that is zone of hypertrophy is. So this is the growth plate you imagine. So there is a straight fracture like this. So this is the zone of hypertrophy. So the fracture going through and through the cartilage, that is growth plate. So this Salter-Harris classification is mainly for the growth plate fractures, right? And type 2. Type 2 is above. A for above. That means it is involving the metaphysis, right? And type 3 is below. L for below. That means it is involving the epiphyse. And type 4 is true. T for true. That means meta, both plate and epi, all the three. And fifth one is crush. That means complete damage to the physis. So the physeal fractures, you have to remember this example of this is key fracture. If you remember slipped capital femoral epiphysis, that is through zone of height. That is one thing. And type 2, you can remember the supracondylar fracture or the lateral condylar fracture. And type 3 and 4. So why am I stressing so much on these types? So from here to here, there will be growth disturbances. Because if you see, it is this damage is towards the epiphyse. So the reserve zone in case of the growth cartilage is at the epiphyseal end. So whenever there is a damage to the reserve zone, this will result in growth disturbance. The first two fractures will not have any growth disturbances. The third, fourth, and fifth will be growth disturbance. What you have to understand in case of Salter has. Now coming to pediatric, this is CTEV, slipped capital, sorry, congenital talipes equinovarus. This is CEV, and usually what we do is we put a serial casing, right? A serial casing is put, and this is an above knee plaster, which is right for treatment of CEV. So what is actually CEV? Congenital talipes equinovarus. So first thing what you have to know, the deformity. Deformity, have you remember? Okay. So there is cavus. Cavus is, and this adduction is seen in the varus hindfoot. And then equinus is ankle. Ankle plantar. So tally pests. Tally means pest means, so there is a deformity by birth which is resulting in plantar flexion and the varus of the foot. Both the ankle and the foot are deformed because of their contractures on posterior medial aspect, right? Posterior medial aspect, all the tendons and the muscles will to contract. So this will result in cavus in the midfoot, adduction in the forefoot, and varus, that is calcaneum, will go into varus in case of hind, and ankle will go into plantar flexion. That means they walk on the toes. These are the deformities. TEV. And how do you correct this deformity? You correct immediately right from first day of birth. So how do you correct it? You correct it by serial casing. Put the casing and you correct the deformity. So what is the order of correction? The order of correction is again CAVE. So there are two important orthopedic surgeons. One is the Ponseti, where we are using. Second one is Kite. So now we are not using Kite. We only use the Ponseti technique of correction, where it is CAVE. That is CAV for correction. So that is the CAVE. And once you are correcting the CAVE, then you put them on this pin. This is called as the Dennis Brown. The two connected, and then finally you give them C. Right? Finally you give them the C connected here. So this is plaster, the Dennis Brown splint, and these are these maintenance. That is your right. And then coming to the what is DH, developmental dysplasia, you have to remember two, Sterlini and Barlow's. So the two important tests. They're the two important screen tests, Otterloni and the Barlow's. How do you test for it? So what is DDH? DDH means that the hip is dislocatable. That means you can dislocate the hip, relocate the hip. So that you are testing on the newborn, which is the screening test. So once you want to bring the what, bring the hip joint outside of the acetabulum, what you have to do? So what you have to remember is bar low. That means you have to bring it outside. Bahar low. That is, you are bringing the hip outside. So how do you do it? So usually it is posterior side leg. You have to. So what you do is flexion, and then you do abduction, flexion, adduction, and internal rotation. Right. So that is how you are bringing it outside. So once you do adduction, the hip joints tend to come out. And for putting them again back inside, you do flexion, abduction, and external rotation. So just remember, bar low, mean bringing out is adduction, and putting them back, abduction. Right? So whenever you want to abduct, they sit inside the acetabulum. Adduction, you have to bring them outside. That is the two screening tests which you have to remember. And now next is, this is the lines. That is Hillingren's line. And then you have your P. Perkins line. Hillingren's line and the Perkins line. H line and the P line. H line is drawn like this along the triradiate cartilage, and along the lateral wall of the acetabulum is your Perkins line, which divide this into four quadrants, right? So here what happens is, normally head sits in the inferior and the inner quadrant, but in case of DDH it goes into outer and upper quadrant. That's it. This is inferior and inner, this is outer and upper quadrant. That's it. And now this is your Shenton's line. The Shenton's line is also appeared break. So why it is break? Because the Shenton's line is nothing but continuation of this pubic rami towards the neck of the feet. So as the edge, because there is a proximal migration of the, there is a break in the Shenton's line. So how do you treat it? You give Pavlik harness. So based upon the age, you treat the patient. So usually, hence, when you identify on the screen test, you give what is called as Pauli harness, the algorithm. So if it is less than 6 months, still give the spleen, that is Pavlik harness. If it is more than 6 months up to 8, you can try for close reduction and put them in hip spica. We have seen the spica in case of the femur shaft fracture also. If it is more than 8, then you go for open reduction. More than 3 years, you go for osteotomies, and if it is neglected, you go for THR, which is total hip. Just remember Pavlik harness, it is more than enough. Now, what is this? This is your Perthes. So, whenever there is an vascular disruption of the femoral head, this will result in a condition which is called as Perthes. This is the Perthes. So, there is loss of sphericity of the sphericity of the head. Okay. 4 to, right? So this cateral classification which is present, classification name cateral classification, and you have to identify the risk of the head, and treatment is by osteotomy. That's it. You do osteotomy so that you bring the head inside the acetabulum and it will resolve. It is a self-resolving. But what you have to do is, you have to see that head is sitting in the acetabulum. That's it. Your work is just to head back into the acetabulum. It will heal by itself. But if you leave the head outside, now the head becomes huge. It becomes large. Magna. The head magna. Now it will cause problems. Whenever you see a patient with Perthes, what is the treatment? Choice of the treatment is just containment surgery. Right? Okay, now what is this? This is Iffy. We have already discussed. This is Salter Harris type 1 and usually seen in males, young, adolescent males, some endocrinal as diabetes, hypogonadism, hypothyroidism, and most probably, right? So these are the certain features of SCIFI where you see a male patient with obesity and certain endocrinological disorders presenting with pain in the hip joint. So there's a pain in the hip joint or the pain in the joint will refer, because there is a referred pain in the hip joint. So pain in the knee or the pain in the hip. And now you take out the X-ray and you see that there is a slip. So this is nothing but there is a slip. Whatever the metaphysis above like this and epiphysis down like this. So this is really appreciated in one important view called as the frog leg lateral, right? So this is about the skiffy. Just remember that it is type 1 of your Salter Harris seen in males especially and young people, obese people, right? Obesity is the main important feature. Next, this is Spindle's shoulder, right? So you can see the scapula. This is failure of descent of the scapula is just yes, and this is fill syndrome. So this even in the picture itself, you can see there is a cervical vertebra problem with low hairline and short neck. So the clipple fill, very very important. Just ask what are the clipple fill syndrome. This is not seen because there are three options for them to from low hairline, short neck, few cervical vertebra, and none of the above, right? So this is the they may form questions and ask you. So this is all the above. Sorry, no, not none of the above. It is all the above. So the answer would be all of the above. So there is cervical vertebra with short neck and low hairline. And now these are the tests for the carpal tunnel syndrome. So what is a carpal tunnel syndrome? So the median nerve compression will result in tingling and numbness called as your carpal tunnel. So the various tests, one is the carpal compression test. This is asked in the exam, which is called as the Durkan's test. Carpal tunnel compression, Durkan's test. Then this is the Fallon sign, reverse Fallon sign, and the tinnitus. You have to just remember the Fallon sign, the reverse Fallon sign. So you're doing flexion. So all this, the dynamics here is you're causing the flexion of the wrist joint where it compresses the carpal tunnel, right? And hence they produce the symptom. Then you can diagnose it as the medial nerve compression of the carpal tunnel. The most accurate. The Durkan's test is the most sensitive. Your direct compression, or it is called as the Durkan's Neophalens. And okay, okay, coming to the infections. So this is the acute osteomyelitis, and this is your chronic osteomyelitis. This is your chronic osteomyelitis, where you see sequest. So the dead bone is the dead bone, which is called as the sequestrum, and the new bone is called as the involucrum. Bone is called the involucrum. Sequestrum, involucrum, mostly osteomyelitis. And what is case of acute osteomyelitis? It's a bony reaction or the periosteal reaction, which usually after 2 of in. And what is this? Gary's. What are the two important? So what you have to remember is what is osteomyelitis. Osteomyelitis is nothing but it is the infection of the bone, right? Infection of the bone, and this is chronic and acute. That are two subacute conditions. That means where the infection is present, but the body is control it. So one such one is your Brody's abscess and the Gary's erosing osteomyelitis, right? So in case of Brody's abscess, what you see is a round-like structure, the cyst-like formation that is seen mainly in case of TB. Gary's sclerosing osteomyelitis is this. So if you see this, lot of periosteal reaction, this is called as the Gary's sclerosing osteomyelitis. Your Gary's, your right. So these two are subacute. So most common organism is staph aureus. Always remember staph aureus. And for treatment of chronic is sequestration. So removing of the dead bone. Now coming to the TB, that is tuberculosis, Mycobacterium tuberculosis, and most commonly involvement of spine and especially dorsal vertebra is right? So here the disc space narrowed. So the disc space is narrowed, especially in case of spine. Have you see? And this is also called as your kyphosis. Knuckle where one is involved, one bone, bus where two, right? Kyphosis is more than three bones are involved. All the picture of the TB tuberculosis where you see the bones are affected and the disc is destroyed. This might result in paraplegia also. What you have to remember, mostly dorsal is involved and knuckle, gibbous and kyphosis. Knuckle is one vertebra, gibbous is two vertebra involved resulting in kyphosis. And now you have to understand about TB hip, right? And the most common area is tabulum is most. And two important things, that is wandering acetabuli. So what is the wandering acetabuli? So here what happens, the acetabulum is completely destroyed. So the acetabulum is destroyed and now the femur head wanders here and there. It moves above and below. Wandering acetabulum or motor or pestle appearance. The motor or pestle appearance, and there are four stages in case. So each stage, first is synovitis, early arthritis, late arthritis, and advanced arthritis. There are four stages. Synovitis, it is the Faber. So there goes into flexion, abduction, stage one. So flexion, abduction, and extension, right? And from stage two, it is farther. Flexion, adduction, and internal rotation. There are four stages where early arthritis is adduction and rotation, very small amount of short. And late is again complete shortening, and advanced is this wandering acetabuli and motor and pestle. So there is a wandering acetabulum and motor and the pestle type. It's very, very important. Motor and pestle appearance is seen in case of tuberculosis, right? About TB, this is the triple deformity where you see in tuberculosis, especially in case of TB. Also, again, it is four stages you have to remember, that is synovitis, arthritis, and triple deformity is. What is a triple deformity of knee? Where you see flexion with internal with posterior So this condition of posterior subluxation and internal rotation and the flexion knee, it is seen in five such conditions, which again remembered as triple. That is your tuberculosis, rheumatoid, fracture, polio, and your hemophilia. LE is low clotting, excessive. Just remember the triple, that is TRIP LE. So there are 1, 2, 3, 4, 5 conditions only you have to remember, right? So tuberculosis, rheumatoid, and ilioband contracture with polio and hemophilia. Yeah. And finally, we are with this important things. One is, this is called the Looser's zone. So what is Looser's zone? It is in case of osteoma. Yeah. Osteomalacia is, what is this? Vitamin D case of adults. We have talked about vitamin D, that is mineralization. In case of adults is called osteomalacia. What is this? This is proteoacetabuli. What is proteoacetabuli? Where you see this head is crossing the acetabulum. These two conditions are seen in osteomalacia, and this is hyperparathyroidism. What is hyperparathyroidism? So there is an increase of H where there will be of calcium, and this is because of resorption. There will be increase of calcium. So this resorption is usually seen in the phalanx of the hand, especially the radial side. Classical of hyperparathyroidism, and this will present as what is called as a Brown's or arthritis fibrosa. Brown's tumor, it can be a differential diagnosis, but this brown tumor is usually hyperparathyroid, right? And these are all image based questions. You can just identify them. So what is this? This is the picture frame vertebra, ivory vertebra, picture frame vertebra and ivory vertebra in case of your Paget's, right? And this is Rugger jersey. This is also you can see in case of Paget's, or you can see hyperparathyroid. So, right? The picture frame is just like this, the Paget's disease, and the ivory vertebra, you can see the entire vertebra is like this, right? Understood? Yes. And now this is codfish vertebra. Codfish vertebra, this is osteoporosis. Osteoporosis, where the quantity and quality of the bone is the quality of the bone is decreased. That is, both the osteoid and the mineral content is decreased. Right? So the bone, the collagen is also decreased, the calcium is also result in this codfish vertebra. And what is the scan which we use? The DEXA scan is one of osteoporosis. Very important. You have the pharma. And now this is bullet shaped vertebra, which is in case of your achondroplasia. Achondroplasia is the bullet shaped vertebra, right? And finally, what is this? This osteogenesis imperfecta, where there is a defective of col A and collagen A1 and collagen A18, which they present as a triad, where there is a bone defect, and then there is a dentigenous imperfecta, that is the teeth are defective, and then there is bruise, right? So what is the important thing you have? But the collagen deficiency effect in the collagen will this imperfecta, where the patient present with multiple fractures right from childhood, because it is a congenital problem. But the healing, well, what you have to remember is this healing is, so you can see that the various stages of healing in one particular individual. So this is the osteogenesis imperfecta, and these are two important foot orthotics. So one is your Jaipur foot, very very important, the Jaipur foot. The first foot identified was this keel. So this is the wooden keel. This is the satch, and now this has been developed by the Jaipur uh, orthopedic surgeon K. where he has fitted this wooden key for vulcanized rubber. So now we use rubber form, and what is the importance of this is all the movements here in the Jaipur, where flexion is possible, inversion, eversion is possible, walking on barefoot possible, batting is possible. Because all this is by the Indian orthopedic surgeon, right? So he has incorporated all activities in patient like this, the inversion, eversion, walking on barefoot, and all. These are all absent of such. You cannot do all these movements. You cannot walk barefoot. You can bat in case of such foot, because it is only a single keel which is present. But in case of Jaipur, there are three things which are united, right? So because of this three important things which are joined here, so there is an flexion possible, version which, right? So what you have to remember between such foot and the Jaipur. Here the soft tissues. So here this is the Dupuytren's contracture. Contracture is similar to the contractures of fascia. So here the myofibro, right? Curve is, just remember that is so that the tendon slit which is present, and the tendon moves inside the sign, and this has certain pulleys, that is A1, A2, A3, like that. And so this in this the A1 pulley is important, and excising that particular tendon, so the tendon moves without damaging one pulley. Trigger fingers, snapping on fingers, right? Contracture is the palmar fracture, cord like structure. So this like structure which you can palpate, cord like structure, Dupuytren's contract. Steroid injection, right? But fasciectomy is the one which is ideal. So fasciectomy, the ideal treatment, but you can trigger fingers again surgical approach. And what is this? This is called the prayers. Prayer sign is diabetic chair, where the patient is able to pray. So you can't all the fingers together. So there is some type of neuropathic joints where you can't actions, prayers, right? And finally, we are done with the uh, lecture. This is the periosteum elevator. So very, very important instruments. And this is osteome. So we have two straight osteotomy and curved osteotomy. So osteotomy is nothing but here this is very sharp. This periosteum elevator, this is blunt. So you just elevate the periosteum. And this is your D. Very, very important. The plate. We have read about nails. Now this is the plate. Where here no callus is there. The callus is there. And if you see oval holes like this is the DC, the dynamic compression plate. And this, if this hole is something like this, right? And now if you see a hole like this with the threads in, now this becomes the LC. If threads are there, locking. No threads are there, this is dynamic. That is, I hope I have gone a little faster for the past 1 hour because I have taken time. Okay. Now, answering few of your queries, I have almost covered the entire syllabus. I mean, most of it is covered. I like the syllabus is completed, and this is entirely based on the previous year's topic. So this must be thoroughly known by everybody because any question particular area cannot be made wrong because this is like the everybody else will know it. So for you to cover the more 15%, I think you can use papers more and more, right? So this particular time which you are allotting for your review with the test, so take a lot of tests and those 50% also will get covered, right? So I hope this session would be more helpful for you. Wish you all the very best. Meet you all in the recall, and let me know how did your exam. And you can scan this for the PDF of this particular lecture, so you be equipped with the notes as well, and you can revise it later day. Okay, and a very big thank you for listening, and thank you for all who have involved in answering questions which have really boosted me up to. Thank you so